first session will be co-chaired by Dr. PrithviMruthyunjaya and myself. Dr. Prithvi will be joining us in a little bit, but I request the first speaker now, Dr. SimarRajan Singh, to talk about Know Your Vitrectomy Machine. I request all speakers to stick to their allotted time because there are lots of interesting talks and we want to hear all of them. Dr. SimarRajan Singh.
Good morning, everybody. For our surgeries. I have no financial disclosures for this talk. So we started exploring the field of vitreoretinal surgery almost more than 100 years ago. But the modern vitrectomy started only in 1970 once the closed systems of vitrectomy were introduced. And we have much to thank to Dr. Robert McAmmer, who is called the father of modern VR surgery, for introducing the closed vitrectomy systems. On 20th April 1970, he performed the first vitrectomy using an all-in-one approach with a single instrument which had the cutting, the aspiration, as well as the infusion. And it was a 17-gauge instrument. Further, we have had modifications of the 3-port approach through the pars plana, the transconjunctival 25-gauge, then the 23-gauge, and now the 27-gauge. So there are various vitrectomy systems that we use. These are some of the common ones that are available all over the world. The Constellation from Alcon, the DORC International system, and the Stellaris from the Bausch & Lomb. There are many indigenous Indian systems also available. I have my training and experience on the Constellation. I'll be dealing mainly with that. But the basic principles are applicable to all the machines. So this is the basic OR setup. This is Dr. Dogra operating in our PGI OT, Advanced Eye Center. So we have the Constellation machine right there, the basic operating microscope, and the viewing system, which can be a microscope viewing system or the newer ones like the 3D Ingenuity. So first, to enter the eye, we use the trocars, which are earlier were the transscleral. We used to use the MVR blade. Now we have the trocar and cannula system, which can go transconjunctival. The cannula stays there and provides a constant conduit to the vitreous cavity. And now also we have the valved cannula systems, which help us to maintain the globe in a much better way rather than the initial ones. The infusion, earlier we used to suture the infusion in the 20-gauge era. Now we have self-retaining infusion cannulas in all the 23, 25, and the 27-gauge, which are retained inside the, which are self-retained in the cannula. Again, the xenon illumination has increased the visibility inside the vitreous cavity, and we also have the self-retaining illumination systems such as the chandelier, which allow for bimanual manipulation inside the retina. The integrated pressurized infusion and the IOP compensation is a very important tool in the armamentarium of a vitreoretinal surgeon, because it basically allows us to maintain the globe all throughout, no matter what happens. So in the newer systems, the infusion goes into the cassette and from the cassette into the eye in a very pressurized manner. While in the earlier system, the infusion went directly from the bottle to the eye, and it was a fixed IOP that was maintained by the bottle height that we kept. Here we can vary the IOP, and the machine constantly tries to maintain it within a range of 2 millimeters of mercury. So as a result, what we get is a hard, firm eyeball, which makes the surgeon also happy. The aspiration system, there are various pumps that are used, the peristaltic and the Venturi pump basically. Most of the modern day systems use a combination of both. The cutter is the main tool that we used for our vitrectomy, and so the mechanics of the cutter is the most important thing. A cut rate is basically one movement in which we suck the vitreous, cut it, and then aspirate it. So nowadays we have cut rates up to 16,000 cuts per minute available. The duty cycle is another important factor which is independent of the cut rate. So at any cut rate with the modern machines, we can vary the duty cycle, and duty cycle means the amount of time the port remains open for the vitreous to come inside. So we have initially we had the electric cutters, and now we have the pneumatic cutters, and now the latest ones, the dual pneumatic cutters, which use the air, which have a separate pump of air for both the cutter going down and up, back up. So that helps us maintain the duty cycle in a more controlled manner. The Constellation provides us with 3 duty cycle modes, which we can vary manually also, but by our default setting there are 3. Core mode, in which the cutter tip remains open for a majority period of time. The 50-50 mode, in which it remains open and closed for an equal amount of time. And the shave mode, when we have to cut really close to the retina, peripheral shaving of the vitreous in a detached retina, in which the port remains closed for a majority of the time and provides more stability and less turbulence in the retina. The cutters have also evolved from the initial 4,500, 5,000 cuts to now the 10,000 cut that we have, the latest, with the bevel tip. So I'll be talking more on that. The bevel tip basically takes us more closer to the retina. The cutter now conforms to the shape of the retina in the curvature, and we can go closer and cut especially the PVR membranes and the diabetic TRDs very close to the retina without injuring the retina. So that is another tool which has come into an armamentarium. And the hypersonic vitrectomy that is coming up slowly, but I don't have a personal experience with this. In this, the vitreous is emulsified close to the tip and then aspirated. There is no cutting of the vitreous in this. So just a basic difference between the conventional cutters and the hypersonic vitrector. The main difference is that it emulsifies the vitreous and this cuts the vitreous. And the hypersonic vitrector, the port always remains open because there is no cutter that is moving in there. It is just the piezoelectric crystals which create the ultrasonic energy and emulsify the vitreous, and it can generate up to 1.7 million vibrations per minute. For aspiration, we have various tools: the active aspiration using the soft tip, or the passive using the backflush probes. The endophotocoagulation probes for the green laser, the curved tips especially coming up, which help us in the photocoagulation of the peripheral retina. The endodiathermy helps us in controlling bleeding, drainage, retinotomy, and marking the breaks. The magnets for the metallic intraocular foreign bodies, both the intraocular as well as the extraocular. We have up to 23 gauge magnets now, so we can even do transconjunctival surgeries for the foreign bodies. The fragmentome, unfortunately, we do not have in smaller gauges. We need to do a localized peritomy, go in for the hard nuclei that are dropped back. And for the oil injection and for the other viscous fluids, we have the automatic injectors which make our life easy because they are very viscous fluid and take a lot of force to inject in and especially to extract out of the eye. So we have automated systems now which help us generate pressures up to 650 millimeters of mercury to inject these fluids into the eye. And there are various other accessories that are present, like the forceps, the scissors, and the scrapers, which aid the surgery in a variety of ways. I am not going into the details. The field is evolving regularly, and just as we heard yesterday, Dr. Mark say, and we'll be hearing more in the VRSI also, about the robotic surgery that is coming up, and that will be something to look forward to. So the vitreoretinal field surgery is an evolving field. Newer advances are being made to make surgery more efficient. It is important to understand the machine that you are using to get the full utility out of it, whichever the machine may be. Thank you.
So thank you, Dr. SimarRajan Singh, for actually finishing your talk in 8 minutes. We have 2 minutes for discussion. Any questions from the audience or any comments? Anand or Kamal, comments? So I have one question to you, Dr. SimarRajan. So is there any case where do you routinely use 25 gauge cannulas, or are there cases where you don't prefer to use a valve cannula?
Majority of the cases we do with the valved cannulas only these days. Only in cases where we use we have to fix the IOLs through the cannulas, we prefer to use the non-valved cannulas.
Yeah. So since the valve not allow some of the very fine instruments to go in, especially if you are trying to do any subretinal surgery manipulation, you have very fine 38 gauge cannulas, it's very difficult to put them in through a valve. That's one case where I have seen that I prefer a non-valve cannula. And also sometimes if you are doing an island transplant, a technique where you sometimes have to bring it out and then put it back in. But otherwise, most cases you can use a valve cannula. Anand?
Alcon for the Constellation is that now you're able to use those plastic bottles which is used by the phaco people. Earlier it had to be the glass bottles because the pressure didn't correct for that.
Yeah.
So when you mentioned the IOP constellation, so that increases the flexibility of any ophthalmic setup. Yes. So it's able to correct for that stiff plastic. That is one. Second thing is on the top right corner of your constellation phase, there is a continuous running monitoring of the PSI, the pressure that is generated. This is not so much of an issue for theaters where they have the compressor right next to the OT, as it was when in my previous institute, at Madurai. Unfortunately for us in Chennai, we have the compressor located at a distance. So the compressed air travels a big distance, and that opens the entire OT complex to pressure fluctuations. So you have to have that constantly. The upper ceiling is 120, the lower thing is 80, so it's 80 to 120. So you can constantly monitor that, and you feel if it's hitting either too high or low, because the machine will shut down the moment it goes below 80. It can be mid-surgery. So that was an issue. That's
good
just
point.
Something.
So fortunately or unfortunately, most of the discussions of VR machine in VR surgery revolves around constellation, although there are other machines also available. But we did a survey of VRSI members as to which machine people use, and almost 80% of them still use constellation or Accurus, and just about 20% use the other machines. So thank you very much for the excellent presentation. I now invite the next speaker, Dr. ManeeshBapaye, knowing your viewing system. Manish. Your podium is this side.
Good morning, everybody. At the outset, I would like to thank VRSI for this opportunity. I'll be talking about the viewing systems. I have no financial disclosures. So intraoperative visualization of fundus is challenging due to multiple refractive surfaces and very small operative field that we operate in. The visualization of fundus can be done using different type of visualization systems, which essentially neutralize refractive power of the cornea and the lens. The recent advances in vitreoretinal surgery, which has led to improvement in outcomes in terms of functional outcome and faster recovery, wide-angle visualization system is an important one of them, along with others like small-gauge vitrectomy system, instrumentation, and illumination. So to start with, we'll talk about the conventional viewing system, which neutralize the corneal curvature, and as we can see, they have very small field of view, of the small field of fundus that we can see. The ones which are commonly used were handheld irrigating lenses, which there are three of them in a set, which give 20 degree, 30 degree, and at the most 60 degree view for peripheral vitrectomy, and they need good assistant to hold the lens. To get rid of assistant's help, the other lenses by Lander's set, which we have used in the past, which can be stabilized using the corneal ring suture to the cornea, and they have variety of lenses for different tasks, like plano-concave lens for core vitrectomy, biconcave lens in case of air-filled eye, and prisms for peripheral vitrectomy, etc. So this is the set that was commonly used, and now it is used mainly for posterior pole maneuvers. The advantages of these are that these are low cost, give erect image, have excellent resolution, and have lesser learning curve. However, they give very limited field of view in especially in periphery, and in case of media opacity and air filled eye, you lose visibility quite a bit, and it's troublesome. So wide angle viewing systems have come in vogue, and they have become popular, and most of us are using them now, which provide panoramic view of the fundus. And they are based on principle of indirect ophthalmoscopy, and the cornea and lens together act as objective lens, while high plus condensing lens acts as eyepiece, and it gives real inverted image, which needs to be re-inverted, and it is done by using stereoscopic inverters, which is a system consisting of two orthogonally adjoint prisms, and it can be moved in and out of path of a microscope as and when required, depending on whether you are viewing anterior segment or posterior segment. The type of them are contact lens type, and the most common one is re-inverting operating lens system by Voke, which has these three lenses commonly used, and the HRX is the latest one, which gives very broad view of 150 degrees, and it can come with their patented design of self-stabilizing and does not require suturing of the ring. Clarivate, again by Vogue, is a patented solid design, and it gives high image clarity, especially in periphery, and it has small design which is helpful in small eyes. The non-contact types, they are the ones who either require inverter or do not require inverter, and the ones which require are biome, which can be one of the earliest systems and which can be mounted on microscope along with dovetail, and has various types of lenses. However, there is no lens turret, so you have to manually change the lenses if you need to shift from one to another, and it requires SDI. It is also available in disposable model, which can be used for a few cases, and then new one has to be used. Merlin Vogue has 90 and 120 degree, which has, there are small size lenses are also available, again for small eyes, and the condensing lens assembly is synchronized with inverter assembly, so that as you pull the lens in the viewing field, the inverter automatically inverts the image without having to deal with it separately. Resight, it's done by Zeiss, and it can be used with Zeiss microscope, especially Lumera 700. There is something called as invertube, which can automatically invert the image once the lens is brought in. Office TopCon system. Office stands for optical fiber free intravitreal surgical system. The illumination is incorporated into the microscope, and optical fiber is not required. Because of this, surgical the bimanual surgery is possible, but the entire system has to be purchased along with the microscope, as they are integrated, and which the cost becomes little on higher side. Dr. Raju from Bangalore has developed a new viewing system which does not require condensing lens, and he has applied for patent. It requires it's called as a Retisite biome because it's a simplified biome, SIM biome he calls it. It's a single lens system and has 60 and 140 diopter lenses. There is no condensing lens required, and Sanjay, the surgeon controls the focusing by microscope. It's simple, and he has applied for patent in India. PWL system, the systems which do not require inverter are PWL system, which has 132 diopter lens and gives erect image, because there are the prism systems are integrated within the lens. This is how it looks. And the one which is commercially available, you can fix it to the microscope, but it can be problematic because maintaining field of view with microscope, and it can hamper patients' hand movements. And Dr. Raju again has developed an adapter to hold the lens, which can move with the microscope and takes away makes it easier to use. The main advantage is that it is much cheaper as compared to the other types of wide-angle viewing system. So coming to advantages of contact and non-contact are in contact, the image resolution is excellent. It eliminates the corneal aberrations and gives very wide field of view. However, moving the eye as we are used to can be a problem, and you have to hold the eye still while doing peripheral procedures. And there is a chance of, if there is a corneal opacity or cataract, it can hamper the view. Vis-a-vis non-contact systems, there is no corneal trauma. We have very good view when we are doing air fluid exchange, but the image resolution is poor, and you need other higher resolution lenses. In a non-peer-reviewed article by Yusuke Oshima, they have done head-to-head comparison of different types of systems, and using model I based on Gullstrand's model, and using US Air Force targets for field of view and contrast measurement. And what they have seen is that the systems are more or less comparable. Probably Resight has slight advantages in different types of scenarios, like water-filled eye, air-filled eye, etc. The latest kit on the block is heads-up display and using digital viewing system. Ingenuity by Alcon, which uses high dynamic range HDR camera with image processing unit and a large OLED display, which is 55-inch ultra high definition and had 8 million pixels. The surgeon and the assistants need to use 3D passive glasses for stereoscopic viewing. Advantages, it can be used even at very low illumination, as less as 5 to 10% illumination, which is almost impossible to use with conventional viewing systems. It's an excellent teaching tool because the assistants and the other people in the OT can see what the surgeon is able to see. The various filters are used which can improve the visualization of the membranes and ability to enlarge the image and peripheral perspective. However, the cost is prohibitively high currently, and there is a learning curve. In the older models, they had image washout in the periphery of the screen, and there is a lag time which apparently doesn't matter so much in vitreoretinal procedures. So take-home points are, it's a wide-angle viewing systems are most commonly used nowadays. Wide angle, but there are variety of choices, and it depends on surgeon's preference and their training. And the traditional contact lens systems still matter because they give excellent resolution and can be used in macular procedures, and the digital viewing system seem to be a future trend in few years down the line. I would like to thank I would like to acknowledge contributions from Dr. Raju from Bangalore, and I would like to thank you for patient listening.
Thank you, Manish. I think you alluded to Dr. Raju many times today. In fact, those who are interested to know more about his inventions, there is a wet lab tomorrow at around 10 o'clock. If you want to sign up, you can still sign up tomorrow for spot registration for that. But then that, Manish, which lens do you prefer for macular surgery versus regular routine core vitrectomy and peripheral vitrectomy? Do you change lenses for ILM peeling and membrane peelings?
Majority of the procedures I do with biome macula lens, but where the membranes are a little difficult to remove and I'm not confident, I still change to the plano-concave lens of the Lander's lens system.
Thank you very much. So we now move on to the next presentation by Dr. Abhishek Kothari. His title is The Art of Recycling Do's and Don't. The view in the Ingenuity system, and as of now, at least the anterior segment surgeries with Ingenuity are slightly more challenging and compared to the posterior segment surgeries, especially some of the time, even conjunctival suturing, I tend to struggle sometimes. I'm not able to find the vicarial suture, on the other end to tie with the needle holder. So some of these challenges are there, but overall it's a good system, the Ingenuity which we have. Should we go on to the fourth presentation if there is any problem with this current presentation? I think I'll have Dr. Kamal Kishore give his talk on basics of diabetic vitrectomy, and then probably once the other presentations settle, we'll go for that.
How do I move to my presentation?
Can we have Dr. Kamal Kishore's presentation, please? Yours is ready?
Oh,
Okay. So we'll go with Dr. Abhishek Kothari's presentation, The Art of Recycling.
Now, as far as I know, I think none of the institutes in India, none of the hospitals in India are adopting a single-use and throw policy in VR surgery. And that is because the most important factor for this is the economics. If you see, the cost of a vitreous surgery in the US or in the Gulf is around $3,500 to $4,000 US, but in India, the per capita income of a person is far less than that. So you really cannot expect a person to pay up front for this kind of single-use surgery. The other advantages are that when you reuse an instrument, you reduce wastage. You reduce the amount of inventory that you have to keep, and you of course reduce pollution by reusing the stuff and not throwing away a huge amount of plastic. Now let us look at the components of VR surgery. The single-use components that we often reuse are the trocar cannula sets, the tubings and the cassette, and the vitrectomy probe or the cutter. Endoilluminators, laser probes, cautery and forceps are already available in the reuse format, so you can have those kinds for your surgery. But the first three ones, you almost always reuse. Now the issues when you are reusing are, number one is the safety, the microbiological safety, the structural integrity, and the antigenicity. And of course, you also have to pay attention to whether your reused instrument is efficacious. Does it perform as well in the first surgery as it does in the second surgery? And for that, I'll be showing a little bit of experimental and clinical results. So coming to the tubings, you have long tubings, mostly more than 1 meter length and about 4 mm in diameter in cutters, in your fluid pipes, and inside your cassette. Now, trocars are usually solid instruments. They don't have cavities, so they are far easier to clean and sterilize. So looking at the safety, we cultured fluid samples and we used the trocars and directly inoculated them onto the culture plates. And the used sets had been re-sterilized, and the fluid lavage from the tubing was sent for culture. We did an aerobic and an anaerobic culture for these tubings, and what did we found was that you had, all of them came out sterile. So the microbiological results were that all the fluid lavages and all the trocars that were tested came out sterile. What I want to stress here is that when you are reusing and re-sterilized thing, you should have continuous adherence to strict sterilization protocols and continuously have surveillance of your sterilization protocols. When you use ETO, you need to have ETO chemical indicators and ETO biological indicators by which you use a process validation, and only then is your ETO equipment safe to use. Coming to the other issue of safety is the antigens. Now, endotoxin and residue can sometimes create problems and give you a task-like picture, a sterile end-of reaction. So for this, we use the fluid lavage and send it for endotoxin assay. And this uses an enzyme from the horseshoe crab. The test is called the BET-LAL or BAL. And the limit is 0.125 international units per ml. This is what is allowed for any intraocular fluid or intraocular medication for use. So the 18 specimens that we sent for endotoxin testing, all were negative for detectable endotoxin. So basically this means that both sterility wise and antigenicity wise, the reused instruments were safe to use. Sometimes when you reuse instruments, you see these kind of residues. If you look in a transillumination light, you see these are basically salts that are deposited from your BSS or RL. So what we employ is that we flush all our instruments with sterile water, first with alcohol and then with sterile water to wash all this organic and inorganic salts away. Now coming to structural integrity, this is what a Alcon trocar looks like at 250, 250, 500, 3000 and 6000 X in an electron microscope. And this is what a DORC trocar looks like at the similar magnifications. Now, after third reuse, you see that the tip, this is the electron microscope of a trocar that has been used 3 times, and there is hardly any degradation of the tip. If you see after the third and the fourth reuse, there is some amount of degradation of the tip, there is some amount of bending, and there is sometimes a proper physical bending also that you can see in some of the trocars. After the 6th reuse, when we looked at high magnification, see actually the tip of this trocar is broken off. So this is what happens when you continuously reuse trocars. First the tip gets deformed and sometimes then it gets broken off. This is the dog trocar after third reuse. You have a slight bending of the tip, which it's more, it's better seen on the cross section. And then after the 5th reuse, if you see that the metal of the tip is getting shredded, it's like the metal fragments that are getting shredded. What are the clinical implications? If you have ever threaded a shoelace, you will realize that when it is in the form on the left, you can easily thread it through a hole. When the tip is shredded or bent or deformed, it is very difficult to put it through a hole. So that basically accounts for the resistance you find going through sclera when you are reusing instruments. So the clinical implication is that there are minimal change in the cutting edge morphology for the first 2 or 3 uses. So you can use it fairly safely. After the 3rd to 4th reuse, observable changes do start occurring. And they are probably responsible for the clinical experience of higher force that is needed to insert these trocar cannulas. We also did a chart review to look at the safety and the efficacy. So we had 170 cases of 23 gauge on retina surgeries. We only choose on retina surgeries because we wanted to minimize the effect of retinal detachment or of, say, foreign body end off. All these kind of cases were excluded so that we can look at the complications happening in these surgeries. Macular holes, ERMs, vitreous hemorrhage were the common indications in this study. New packs were used in about 49 cases, and the reprocessed packs were used in 121 cases. And the parameters we were looking at were the incidence of endophthalmitis, the incidence of a sterile postoperative reaction, sclerotomy-related breaks and peripheral breaks, and the need of sutures to close the sclerotomy. So what were the results like? We did not have a single case of endophthalmitis in this whole series. There was one case of unusual sterile reaction, that is more than +2 cells in the anterior segment in the reuse group. There was none in the new group. This was not statistically significant. There was no statistically significant difference in the rates of iatrogenic peripheral retinal breaks. There was one in the periphery in the new group and 2 in the reuse group. There was a statistically significant higher need for sutures in the recycled cases. So sometimes we did have to use sutures to close the sclerotomies. They were not always airtight or watertight. So to conclude, the safety of instruments established, you can very well reuse the instruments if you follow strict protocols and adhere to sterility measures and use a continuous monitoring of your sterilization protocols. The efficacy of these instruments is preserved till almost 2 to 3 uses. The lab results do show some degradation, but only after the 3rd or 4th use. What we advise is that clinical judgment needs to be used to ensure better results. If you find that a cutter is not cutting, or if you find that there is too much resistance to a trocar cannula going inside, then you should change. Proper documentation is also essential. So this is a consent that we take, in which we have a very clearly written line that states that the patient has been offered surgery with a brand new set and with the option of reuse at a lower cost, because the patient cannot afford surgery with the brand new set because of the cost involved. We also write that if during surgery with a reused pack, if there is any degradation of the quality, or if the surgeon finds that the reused instrument is not performing up to the mark, we change the instrument and go for a new instrument. So if this is written and if this is explained to the patient, at least legally we are a little safer. Thank you.
Thank you so much, Abhishek. It's a very nice study that you did. Congratulations on that. This is something which I think all clinicians should have. This must be a passion which generates a research question, and you went completely after these questions and did all the studies on this. So I think since we had some time lost during the transition, Anand, unless you have some yeah. So but then we'll come back during the last panel discussion if there is time to take more questions. But we will move on to the next talk by Dr. Kamal Kishore on basics of diabetic vitrectomy.
Good morning, and thank you. It's great to be here, away from -5 degrees weather in my hometown of Peoria. And thank you for giving me this topic, which is near and dear to my heart. So surgical goals in a diabetic vitrectomy are to clear the media and to reattach the macula. Other goals are to remove the membranes, to remove traction as much as possible, hemostasis, PRP, and minimize and delay complications. And as much as possible, try to avoid the oil, because you want to maximize the vision. So let's run this video. And so first rule, for TRDs, operate only if macula is detached. This patient has stayed like this for more than 10 years. And studies have shown that macula preserved TRDs, extramacular TRDs, they have annual rate of just about 10%. So these cases can be difficult. So each case is unique, but there are 5 things that you should know. First, there is usually a peripheral PVD. Second, posterior hyaloid and membranes are continuous, so be aware of transmitted traction away from the site of your work. Third, there is vascularity, it's variable, so pre-op laser and Avastin help. Usually one temporal arcade is the worst one, and the second one is easier. And be aware of retinal thinning and atrophy. It tears easily, especially nasally and periphery. So have a plan. but of course make adjustments. So there are 5 things that you should know. First, relieve anterior traction first, cut the cone. Second, divide the tissue between 2 arcades or free up one of the arcades. Third, the hardest membranes should be tackled last, so that if there is bleeding or breaks, that should be delayed as much as possible. And don't be too aggressive with nasal membranes. This is not cancer surgery. Forget en bloc. It's not needed. Your goal is to reattach the macula. Now, learn this part. So learn to use cutter as a multifunctional tool. You can use it as a vertical scissors. You can use it for delamination or membrane removal. There are 2 techniques described, and we'll come to them again. One of them is fold back, where you let the membrane fold into the cutter. The cutter stays on top of the membrane. It is safer, but it's not always possible. The second is what is called conformal, in which you are in the plane of the membrane or retina. So sometimes this has to be done, but you lower the vacuum. So there are 2 essential maneuvers you need to know. One of them is being shown here. That is, you somehow get under the membrane and cut it. So this is called cut and lift. And this is safer, this is preferable as much as possible, but sometimes it's not. Then you have to use the cutter as like a snow shovel or something, which is you jam against the membrane. And of course you lower the vacuum. So there are 3 final points I'll talk about. The first is be aware of vitreoschisis or vitreoretinal, as we call here. So this is what is shown here. So if you're on the correct plane, the membrane will come off. If you're on the wrong plane, it will not come off. So if the membrane is not coming easily, be aware of it. Second, try to avoid cautery as much as possible. It causes necrosis, creates breaks. And if you cut neovascular tissue flush with the retina, there is muscularis there. It goes into spasm, and I can do entire case without using any cautery. And of course, you want to avoid unnecessary exchange of instruments. Second final point, scissors. Learn to use scissors as a pick. It's very useful. So you're trying to do is lift the membrane with your scissors to expose epicenters, and take small bites, because that will cause less traction. Stay inside out as much as possible. Try not to do spreading motions like general surgeons do. If you spread like that, you will cause retinal breaks. One-handed will cause less traction compared to two-handed. Third, bimanual. So sometimes you have to use bimanual, especially in patients who have combined traction rhegmatogenous detachments. Lighted pick works very well, as shown here, but of course you can use chandelier and forceps. The goal is to avoid traction on the retina, and the second instrument is mainly to stabilize. If you use a pick, the pick can show you where the plane for the cutter is, and sometimes you can use the pick as shown here, just like you use a chopper in cataract surgery to keep the retina back. And as you can see here, this is actually pick, lighted pick. There is some glare, but I'm sure you can see it. So we can let it run, or we can. So this is the pick again. Pick is being used to lift the membrane, and then you cut the epicenters with the scissors. And this is the same case. You can see there is one break there. It was pre-existing, and you can do fluid exchange followed by air exchange, and it's all good. Okay, so you can just move forward. So now put it all together. So this is a patient with the traction rhegmatogenous detachment. So in this case, as you can see, I am removing posterior hyaloid very meticulously. Take your time. It's just kind of play with it. It's okay. Just take your time, and once you are done with removing peripheral traction, then you come, like here I'm done. Now the inferior arcade is easy to free here, and you just free it, and I'll keep doing all this. And the hardest part, which is along the superior temporal arcade, I'll tackle it last. And here it comes. This is my flat lens. You go under the membrane with the cutter, and this is my light pipe, just for little counter traction. Go under it and cut it. So once you have cut it, it becomes a lot easier because you will not cause break at a distant place. So this is fold back delamination being shown. Membrane just deforms into the cutter. And now this is conformal, and you can just keep doing it. So just take your time. This is, you do almost all these cases with the valve cannulas. It's under control, local anesthesia. There is no need to rush. And I can guarantee you, just by doing this, you can do most of these cases in under an hour. And this is bimanual. And same thing, you can just see the forceps lifting the membrane. And here it comes. We can probably just advance it a little bit, and so this is another case. Maybe I can go there. So now we are removing the membranes. This is a little bit more challenging, but this shows a very important point. If you ever make a break, your goal is to make sure that there is no traction on the brake anymore. I can go a little bit forward. This is another technique. This is chandelier, and you use cutter as like a dissector. This one, I don't use that anymore, and I'll show you why. So you're trying to hold the membrane of the forceps, and you're using it like skinning an animal, but you can create a break, especially in a bad case like this where retina is very thin. But it shows a break forming, and if it happens, not a problem. Make sure that there is no traction. Don't go anyplace else, because sometimes there's a tendency that you create a break and you go someplace else, then there is bleeding. It's very hard to work there. So that becomes like your karma bhumi. You just have to work there until you have relieved all traction. And after that, it's easy. You can just go forward, endo laser, and this patient actually did quite well. So first patient, hand motions. I'm sorry, is my time up? It's okay. So here some membranes could not be removed, but this is the last point I have. Some of these eyes will not do well. These are ischemic eyes. Many of these are end-stage eyes, end-stage patients. Always keep learning, but don't be hard on yourself. Learn to forgive yourself. Learn to forgive your colleagues. But some things are beyond your control, no matter how hard you try. Never criticize another doctor. Thank you.
Thank you, Kishore. It was a very nice presentation. Can you just stay back, Kishore? Kamal? So, if anybody from the audience can also ask questions. So, I just wanted to ask, for the excellent videos, I didn't see much of bleeding in most of your cases. Do you routinely use Avastin in your cases pre-operatively?
Yes, almost all.
Yeah,
First of all, I use as much PRP as possible. And second, about 3. Oh, I'm sorry.
It's on now.
Okay. So about 3 to 7 days before surgery, I give them Avastin. And third, very important, valve cannulas. That keeps your eyes stable. And if there is any bleeding, just increase the pressure to 60, and then the bleeding will stop.
Okay. So one last question. Any tips for if you have bleeding at the end of the surgery, there's a thick layer of blood clot over the macular disc. You have any tips on how to handle it?
So first is prevention. Anytime there is bleeding, just increase the pressure and see. But like in your case, suppose there is now thick blood covering the posterior pole, and the blood has clotted. That's the problem. If it is unclotted blood, that's easy. But if it is clotted, then you can use either extrusion. Just be aware where the macula is. Try to be near the nerve or one of the arcades. And sometimes I have used forceps. It works. So if you use forceps, try to avoid those pointed forceps, like maxi grip type. Just use something like ILM forceps where you can open them wide and you have more grasping area.
Thank you very much. Anand, you have something?
Anand, any? I'm sorry, at the end of the procedure? No, I don't. I have heard about it. I know about the controversy. The argument is, for the sake of audience, that once you have done vitrectomy, the Avastin is gone. But actually it's not gone, because it is still attached to the tissue. So I give Avastin post-operatively only if there is bleeding.
You mean, is your question intraoperatively at the end of the surgery or after?
At the end of the Correct. So at the end of the surgery, I don't. No.
Yeah, I used to routinely give. I didn't find any benefit in terms of post-operative outcomes at 1 month. So I'm not using it routinely now. Yeah, Dr. Jain. Yeah.
Raja, yeah. So to continue from where you left, Dr. Kishore, excellent videos. As a preventive step, we can't allow bleeding to take place. I mean, huge quantity of blood to accumulate.
Correct.
Because once that happens, then it assumes the shape of the original membrane. And the difference being this time is everything is covered by a layer of clotted blood. And one good maneuver could be, what I have found it useful, using bimanually, using soft tip cannula with the left hand or the non-dominant hand, and using scissors, because to find out the planes of cleavages beneath a clot is very difficult at those times. So this is a very good maneuver.
There's one other innovation. Our colleague Dr. Padmaja in LBP, she has started, I mean, wherever it's possible to remove, you remove, but I know it's so difficult sometimes. You start pulling, the retina is getting pulled up, you're not sure, are you going to create another break or not? So while we may say I attempted, but many times you may have to just leave them. But what she has started doing recently is injecting intravitreal triamcinolone at the end of the surgery, just over it, and it dissipates by the next day or in 2 days. Most of the blood clots are gone. So that's something which you may also try and see if you get the similar result. But we have seen fantastic results that day one you see the entire blood has gone.
Actually, I just have just one comment.
So just a small point. If the clots are small, of course you can leave them alone. But if you're talking of a large sheet, a little difference here. I don't think pulling with a max grip, it can create breaks because it's quite adherent to the retina. Okay. So what I do is go again in fluid. It takes around 5 minutes more and it dissolves, and then you go again in air after lasering all the bleeds or cauterizing all the bleeds. So go again in the fluid. But pulling with the max grip sometimes creates problems because you don't have a cleavage plane and you can pull up the retina also.
Yeah, you have to be careful. Thank you.
It's a great point. Actually, one last thing along the same topic. I had a patient about 2 weeks ago, and I was doing a case like this, just like that, doing it. And I had no idea that there's a branch of aorta in the optic nerve. So it's like big fountain of blood came. So I tried everything I could, tried perfluoron, tried to work under air like Steve Charles talked about, I could not see. So what I did, I said, you know what, it's okay. Before I do too much damage, I just closed the eye, went back. A week later, I gave the patient one more Avastin. In fact, I have a nice video on that one too, but it's a limited 10-minute talk, and turned out great. So the point is, there is always tomorrow. So before you do much harm, it's okay. You can fight some battles next day, next time, next week, next month.
Very nice point. Thank you, Kamal, for coming all the way from Chicago to Jaipur. Thank you. I now invite our next speaker, Dr. SubinaNarang, talk on scleral buckling.
Good morning, everybody. At the outset, I would like to thank the organizers and scientific committee VRSI for giving me this opportunity of coming here in the wonderful, colorful city of Jaipur. Scleral buckling, I'm going to tell you something very, very basic. The outcome is nowadays is not significantly different from past planar vitrectomy. There are numerous studies which have come up. So the scleral buckling still has a role in today's world of vitrectomies. Why do we prefer scleral buckling in certain situations? Like if we have a young patient, my first preference would always be doing scleral buckling, because induction of PVD, which is a must for doing vitrectomy in these retinal detachments, is difficult in these patients. This is not shining, I don't know. Vitreous tamponading agents, they always have a risk of development of cataract, be it gas if the patient is unable to maintain the prone position, or silicone oil, the patient would land up having cataracts. Refractive errors which are induced by vitreous substitutes are also considerable, so patient is going to lose vision temporarily. In case it's a macula on RD, we would in fact prefer scleral buckling procedure for these patients. The most important skill required for surgery is identification of the breaks and adding all the breaks and any additional area of vitreoretinal pathology or traction which is present. After doing this conjunctival peritomy, blunt dissection for the blunt dissection should be done for the posterior clearing of the conjunctiva, and then you bridle the muscles. You start with, after localization of the break, in case your planning is to have a buckle there or encirclage band, you can go 12 millimeter from the limbus, or maybe the highest, the most prominent point, equator. And once you pass your sutures, the needle track has to be visible all throughout to prevent the perforation in the eye. If your buckle is 2.5 millimeter of width, the suture bites have to be 3 millimeter apart. So there's slight indentation here. After securing this suture, after securing your buckle with first suture, then you can go ahead, 360-degree sutures can be, band can be passed, and pass these sutures in whichever quadrant you are not planning to put the buckle. In the quadrants you are planning to put the buckle, you apply the sutures which are not the permanent sutures like this. They should initially be, like if I'm planning to put 277 buckle, I would be applying the sutures 9 millimeter apart. This is the quadrant where the break is. The break should fall on the interior part of the buckle. So again, your track of the needle has to be visible all throughout. You pass these mattress sutures here. The width is depending on the buckle you want to put, and apply the slip knots here. The knots will be tied only after you do the drainage, and the buckle will be passed after that, because in case you do it first, then it'll be impossible to drain, and your drainage, maybe I try draining under the buckle, so that in case I land up having a perforation, it would be spotted by the buckle. Of course, once you're doing the drainage, be sure that you're holding the two brittle sutures yourself, because you don't want unnecessary traction. Slowly you separate the scleral fibers. Try doing it on upper side or lower side of your horizontal recti muscle. Avoid the vortex vein area, and slowly separate the scleral fibers. The moment you get slight scleral bulge, go ahead with Kothari of these. This will prevent the buckle, and then you slowly perforate. You could do it with 26 gauge needle, or you could do it with a 50 Dacron needle. In the end, you tie the 240 band. Now, I would be covering the key steps slowly. It's just moving on its own. So first, most important is localization of the break. For localization of the break, you have to do 360 degrees examination, because many times you could find another break in attached retina. So you should do, again, though you have checked the patient in your OPD, recheck the patient, indenting all the quadrants 360 degrees. If you have additional breaks, just identify them, and maybe you have to change the plan intraoperatively also, because you get to see new breaks. And once you have put the mark, identifying the posterior most part of the break, then you reconfirm it with localizer. If you're comfortable that this is the break, then we go ahead with cryo. Cryo in the same meridian has to be passed. You depress at ora and gently move it posteriorly, you will be hitting the break. And the direction of the direction indicating knob of the handle of the cryoprobe has always to be facing away from the surgeon. And the moment you stop the cryo, you see the effect, you go ahead with putting water there. The scleral buckling, there are various buckles available to us. Now, in case you have multiple breaks, you prefer a circumferential buckle. If you have a radial break or single break, you prefer a radial buckle. And while passing through sutures, you should be able to see the needle track like I showed in my previous surgery which I showed you. Now, commonly encountered problems are, there could be inadvertent perforation. They could be placing the sutures beneath the muscle could be risky, and associated lattices and atrophic holes. You need not cover cover all of them with buckle. In fact, they can be sported only with the band. In eyes with 360-degree lattices and atrophic holes, and you feel that is the cause of scleral buckling, you could go ahead with broader encirclage 4 millimeter long and alone, and place to support the posterior most lattice which is there. Now, innovations in scleral buckling is that you could go ahead with the sutureless buckles. Now, sutureless buckling can be used for, is preferred only for 1.5 or half a quadrant. The buckle can be placed posterior to ora serrata in cases when you have posterior breaks, because it is said that the anterior edge should extend at least 3 millimeter anterior to the break. That's what is required. Or maybe you could go ahead with innovation. If you see lower one, you have just made a wider buckle. So wider buckles can be used. SRF drainage, I told you, under the buckle, I prefer doing it, and preferably it should be upper and lower edge of the horizontal recti muscle, away from the choroidal area of vortex veins. We prefer doing it under magnification. The moment we see this SRF gushing out, you just leave all traction onto the globe and depress one lip of the wound scleroscopy site what you have created. Then to prevent, sometimes what you have is you have gross hypotony when the things drain out, and choroidal detachment could be there. So there's another innovation. Innovation is that you can have a infusion-assisted drainage. So you could have this infusion cannula here, which is shown in the upper thing. Or you could have needle drainage under visualization. If your shifting of fluid is present, I have never done that, but yes, under indirect ophthalmoscope, you have a needle 26 gauge, which is going back long 26 gauge, and you could drain it under visualization. Summarizing, the fundamental goal of scleral buckling is the functional closure of all the breaks, so that normal physiological forces can maintain the permanent state of attachment. Scleral buckling cannot be forgotten art. So anyways, even in today's modern world of vitrectomies, scleral buckling has its own position. Thank you very much.
Thank you, Dr. Subina, for the excellent presentation. I think scleral buckle, we used to call it a dying art, but it's not dead. It still survived, has survived, but it's stagnated kind of. I'll just tell you one story with a heavy heart. Recently, I sometimes do chandelier-assisted buckle for teaching purposes, and I had recorded one video and I was just playing it. And a young VR surgeon just sitting next to me, I just asked him, so do you know what this step is? I didn't tell him that it was part of buccal surgery or anything, but I just asked him what's going on here. So he said, after a while, after a lot of thinking, he said this is early hypofluorescence with late hyperfluorescence. So that's what the situation is probably at this time. But Ken, are you doing buccals, and what in Malaysia, if are you, how are you teaching buccal surgeries to young surgeons? Can we have the mic on, please? Can we have the mic on?
Yeah, thanks for the question, Raja. It's the same dilemma we have all over the world. We still do buccals, maybe about 10% of retinal detachment cases. It's the same way, I mean, you just have to encourage them to do it. One important aspect is that it's so much more cost-effective than vitrectomy. So in terms of the technique, it works, and it's, you know, the savings are there. And the main key really is to encourage the trainees to use the indirect in the clinic. Because if you have no skills using the indirect ophthalmoscope, then you can't possibly do a good buckle. So I think they have to, all the trainees have to be able to assess the patient with the indirect ophthalmoscope in the clinic and detachment, draw the diagrams properly, and identify all the breaks regardless of whether you're going to do a vitrectomy or a scleral buckle.
I agree with you, Kenny.
Yeah, just a quick comment. One thing is we cannot allow scleral buckling as an art to die. I think that's one of the things of VRSI. Second thing is, I think for any of these pediatric RDs, where you have a peripheral break, nothing, even it's inferior, nothing like doing a buckle. It's a huge hell of a mess trying to go in and detaching the vitreous from the retina. So I think that skill of doing a buckle in pediatric RDs, where it's possible to do buckle, as well as chronic RDs also.
Thank you. Abhishek?
I just have a small suggestion for VRSI. We can invite Dr. Ingrid Krisig. She's probably the lone crusader who's been fighting to, pass on the skill of buckling to generation. She has been having a course all the while in Retina. So we can probably have a session on buckling, because I don't see any session completely devoted to scleral buckling. I think
wonderful suggestion. We'll definitely take it up. I invite the next speaker, Dr. Rajeev Jain. He'll be talking on vitrectomy for endophthalmitis tips and tricks.
Good morning, everyone.
Thanks, Narayanan, for calling me here. Thanks, VRSI, for inviting me here for this talk. So the management of endophthalmitis, it revolves around intense medical treatment and surgical intervention, with salvaging the eye and the vision being the primary aim. So what do we achieve by vitrectomy? The goals of vitrectomy in endophthalmitis are to kill the organism, block the inflammatory cascade, remove the inflammatory debris from the vitreous cavity, and prevent and treat the complications of this infection. And early vitrectomy has its own advantages. We can obtain early sample for vitreous culture and can start the specific treatment. We reduce the bacterial load and the toxic products in the vitreous cavity, which can cause damage to the optic nerve as well as the retina. It clears ocular media, so you can assess the severity of the disease and treatment response. And obviously it increases the retinal oxygenation. Before endophthalmitis vitrectomy study, there were widely divergent opinions regarding usefulness of vitrectomy and the timing of vitrectomy. However, EVS study, which was the largest randomized prospective trial done in 1990s of 420 eyes, showed us a way. It was the first insight into the timing and management of endophthalmitis, and it gave us certain guidelines. And they actually proved that in cases of patients coming with vision of better than light perception, there was no statistically significant benefit in patients undergoing either vitrectomy or injections. And the other thing was, patients who came with light perception, there were 3 times more chances of having vision of 20/40, 3 times more chances who underwent vitrectomy for these guys to have better vision than the group which underwent injections. Other thing which came with EVS was, although the patients were randomized in both the groups, the complications of retinal detachment was 2.5 times more in injection group, and the number of patients going into phthisis was almost double in injection group. Our management today is, since the technological advances in vitreoretinal surgical procedures and instrumentation with better visualization system, our approach for endophthalmitis vitrectomy is mainly guided by clinical picture and the course. And there are definite advantages of going inside the eye early as compared to late vitrectomies. So these are the dilemmas which we face while we are doing endophthalmitis vitrectomy. I'll come to these points. The important point which I want to highlight here is, often these are the cases where we compromise with the instrumentation. So we need to have a good cutter. And since Abhishek was talking about recycled cutters, I recently changed it to put new in brackets. So it has to be a good cutter, need not be a new cutter. And sharp trocars and cannula, so as to put minimal traction on the peripheral vitreous, because in these eyes the retinal tissues are friable, and undue traction on the vitreous can create unnecessary breaks and detachment. The surgical technique is similar to standard 3-port pars plana vitrectomy with few exceptions. Securing the infusion cannula is important. Most of us have shifted to 23 gauge trocar and cannula system for these vitrectomies. However, colleagues who are doing 20 gauge, we use longer infusion cannula, 6 mm preferably. If we can visualize, we can go ahead with the vitrectomy. If we are not able to visualize the infusion cannula, then it's better to have a handheld infusion and clear the central vitreous behind the IOL with the cutter, and proceed with the vitrectomy only after we have seen the tip of the infusion cannula. And it is important to clear, most of these cases we need to remove debris and hypopyon from the anterior chamber to make the media clear. So sampling technique, what we use is, we attach a 5 ml syringe to the aspiration tube coming out of the cutter. All the cannula is placed, infusion port is fixed, but the infusion is off at this stage because we want vitreous biopsy sample which is undilated for the better culture results. High cut rate is put, no automated suction is used. After cutting sufficient vitreous behind the IOL, we gently aspirate with the syringe. Care has to be taken at this step that you do it yourself. Don't let your staff nurse to do it, because
It has to be done very gently so as to reduce any traction on the vitreous all around. And at that time, you take the cutter out and aspirate the remaining fluid which is there in the tube into the syringe, and you send this sample for microbiology. Switch on the infusion. You have to remember that at this stage you can't aspirate a lot of vitreous from the eye, because the eye may go into hypotony and the infusion cannula might touch the retina. And we routinely send cassette sample for microbiology too. So a case of endophthalmitis, as I said, clearing of anterior chamber is very important. There may be hypopyon, there may be membrane over the pupil, and most of them, they have some synechiae also if endophthalmitis comes 4 or 5 days later. And what we do is we irrigate the anterior chamber, we clear all the hypopyon, and then we make sure that we go under the pupillary margin to remove the synechiae which are there. Sometimes we use viscoelastic to stretch these membranes so that you can remove them with the forceps, just take them out. So this is very crucial for the proper visualization of the posterior segment, and this step has to be done in the beginning itself. Once this is done, then you can go ahead with your routine vitrectomy, whatever you've planned. So this is a case of where core vitrectomy was done. There is a lot of stromal edema, and once we were inside, we could not see retinal details. The retinal details were not very clear. So these are the cases where we do core vitrectomy. We don't chase the vitreous too much because we cannot see the retinal details very much. We do a core vitrectomy, debulk the vitreous cavity, and there was a lot of stromal edema in the cornea. So whatever I could remove easily, I did it with high cut rate and low suction so as to put lesser traction on the friable retina. So our goal is complete vitrectomy in certain cases. Traditionally, so this is how we attach a syringe to the aspiration port of the cutter, and after cutting the central vitreous behind the IOL, we aspirate with this syringe. So traditionally, it has been taught that endophthalmitis vitrectomy has to be a core vitrectomy so as to do less damage to the retina. But with the advancements in, as I said, with better visualization systems and our vitreoretinal techniques, we have become more aggressive. Now our approach to a case of endophthalmitis vitrectomy is not just governed by we go in when there is perception of light or worse vision. We go in early also. So after clearing the central part so that I can see what's happening inside, and once I start seeing the infusion cannula, that is the time I switch on the infusion port and go ahead with the regular vitrectomy. In these cases, as I said, high cut rate and low suction is the key. Don't chase too much of vitreous. Send the samples, as soon as the samples are out, one of my assistants takes it out and send it to microbiology. We don't want sample to be with us for a long time. And so we go in for these vitrectomies, we don't wait vision to become light perception. More than that, we see if the red glow is not very good, even in the first instance, the red glow is not very good, we are not able to see retinal details. We go in for early vitrectomy in these cases, and our results have been very promising. As I said, some of them have PVD already done, but if PVD has to be induced, it has to be slow PVD, and normally we induce the PVD under direct visualization. Wherever PVD is extended, it has to be under visualization so as to see there is no undue traction on the retina. Don't chase vitreous too much because you can produce inadvertent breaks. And there was a hemorrhage while I was doing vitrectomy in the while I was removing the peripheral skirt. I didn't see the break, but I knew that there was some break because this blood has come. There was a bit of subretinal hemorrhage as well. So in this case, I had put oil. So that's another discussion point, which cases silicone oil can be used. I'll discuss that as well.
Can you wind up your presentations?
Yeah, thanks. So I think there is no role of intraocular tamponade in routine endophthalmitis. However, if we create retinal breaks or retinal detachment, that is the time we use silicone oil in these cases. I think I'll wind up with this slide and kindly block your dates for Delhi Retina meet, which we have decided to be held on 24th and 25th of August 2019 in Delhi. Thank you.
Thank you, Rajeev, for the excellent presentation. Since we don't have much time for discussion, but I will have one comment from Avinash, one of the foremost experts in management and endophthalmitis. So Avinash, how do you plan, I know you give steroids in case of endophthalmitis intravitreal, so how do you plan your management, and I know your outcomes are very good, so when do you decide to give steroids? Can we have the mic, please?
Extremely debatable in the management of endophthalmitis. So to start off with, no role, I don't do steroids in case of fungal endophthalmitis. I don't do steroids in low grade or chronic endophthalmitis. And when there is a high chance of suspicion, we are dealing with the drug resistant organisms also. So these are the absolute no's, the fungals, and the delayed postoperative endophthalmitis, and the multi-drug resistant organisms. Now, having known the don'ts, otherwise in all cases of acute postoperative endophthalmitis, I use dexamethasone.
So can I just ask you, so do you wait for the first culture and then give the steroid, or do you just go in during the first surgery itself and give steroids?
In acute postoperative endophthalmitis, again, there is always controversies because the medical fraternity has been divided whether to use corticosteroids or not in infections. So there is no way you can have a sort of a common path for both of them. So people who tend to use steroids will always tend to use steroids. So having said that, in acute postoperative endophthalmitis, my preference has always been to use dexamethasone because of its it works for about 24 to 48 hours, and most of these acute postoperative endophthalmitis has been bacterial. So that is the reason why I prefer to use dexamethasone. Another steroid I also like to use, but I would have a lot of caution in the fraternity to is I use a long-term steroid, triamcinolone as well, in cases where the infection has been curtailed to a good extent, and when we know what organisms we're dealing with, and the antibiotic sensitivity has been obtained. So these are the three parameters where I would like to consider to use triamcinolone as well in selected cases. So this is the role of steroids, I would say, in terms of intraocular.
So thank you, Avinash, and thank you, Rajeev, once again. We'll now have the next talk by Dr. AnandRajendran on best approaches for complex retinal detachments.
So good morning, everybody. It's great to see a full house here. And a lot of my talk has been made easier by Dr. Kamal Kishore's excellent talk earlier, and I just removed all the theory slides sitting out there because he'd done it so elegantly. So I'll just go show you a bunch of videos and take you through what I think should be the approach. So we'll go first with closed funnel RD with PVR, which is something which is pretty challenging for most people, youngsters and things. So first, this is a case with a very small pupil and with a posterior capsular opacification. So you deal with that first to get your illumination in. And then the first thing is there's a huge amount of glosses right there. So to open that funnel, first and foremost, so what I use what I call the banana peel technique, where I go in with a cutter and unimanually. Important thing here is to go radially, go along the closed funnel. So as you can see, I'm just teasing that, and then you open that, and then once you get access to this closed funnel, put in that PFCL. This PFCL will now push that closed tight RD to the walls of the globe and open it up, and you can see it's pushing the resistant detachment and opening up that funnel, and you're creating that cavity space out there. And then you go ahead further, go deeper with the cutter again and do anterior radial segment. Again, the banana peel, like I said, go along the funnels, don't go horizontally. Now I'm inserting the cutter in that gap between the closed, the RD and the gliotic element, cutting up. It's important not to turn, this is important not to turn the cutter the other way around, otherwise you'll knock off the retina, and keep going like that and removing that. You can see how tight it was. Then because this is such a thing, I knew I do need to do peripheral bimanual excision, so I'm holding that peripheral gliotic tissue, and then like Dr. Kamal also said, small snips, first small snips, don't open the scissor full length and cut. You get greater control. It's much better to do 5 or 6 small snips rather than one big snip, because the scissor, if it opens too much, the crunch effect on that membrane can create tears just beneath that. So you just go ahead with that. and relieve that, and I'll just move on as I keep doing that. And this is another tough area which, notice that we're just holding that, the left hand is very important, and throughout the rest of the bunch of the videos I'm going to stress upon that, the use of the left hand. Everybody looks at the right hand, but it's the left hand which is important also. And here there's some retinectomy being done for recalcitrant, this thing, and then I flipped the retina over and removed some subretinal membranes. You can do that, and just shave off that edge so you get a smooth edge peripherally, and then put in some more PFCL, and then finally affix it with the laser. And then if it's such a chronic detachment, I sometimes prefer to do a PFCL, silicone oil direct exchange, where the right hand puts in the PFCL and the left hand is aspirating that, the PFCL, and the right hand is putting in the oil. So we'll go ahead next with a complex diabetic TRD, a posterior bimanual surgery. Dr. Kamal has shown us plenty of good unimanual ones. I'll just show you this. So this is the same concept applied to the posterior pole. So you have this very chronic posterior pole involving diabetic TRD, where you're holding, again, you can see the left hand is just holding that membrane, and the scissors is inserted. The lower flange of that is being, in a way, used as a pick. I think Dr. Kamal also alluded to that. So insert in that thing. Getting the right plane is most important, critical. Visualizing that right plane is the first and key step. Once you do that, most things can be done fairly easily, and you can see that you can use the same horizontal. When you're using MIVS, you can use the same scissors as to delaminate as well as segment by rotating it in your hand. You can see that I'm rotating it and sometimes segmenting, as well as sometimes right now I'm delaminating it. So you can use it both ways. So with the MIVS, we have this concept of vertical scissors kind of gone. Okay, so we'll move ahead next to show you a cartoon of the same thing. You see, this is posterior bimanual surgery. So the left hand is picking up that membrane, and the right is just snipping at that junction, exact area, and you see how the membranes are supposed to come off. And the next one will show you unblocked dissection, which if you've got a complete funnel removal of the vitreous cone, then you can just use unimanual dissection to remove that entire cone off. Okay, now this is a tough FEVR, familial exudative vitreoretinal detachment surgery being done, and you can see that first, of course, the most important thing is to always, as a principle, do the simpler things first. So remove the vitreous from all the periphery where there is hardly any detachment. You can see there's a very excessive, strong detachment pulling the entire retina temporally. And you can see the retina has been pulled over the disc from the nasal side onto this, so you have to approach gently, alternate between the forceps and the scissors. You see here I'm using the forceps to gently drag the tissue off the disc, and you just pull it off, and you use the cutter can be used not just to cut, but also as it's a smooth tipped end, so you can use it gently dissect it off. You can tease off the thing. So sometimes, some points you have to alternatively make that adjustment. So you just move the thing, say I'm alternating between cutting and actually teasing it off. And you see, I'll just move ahead. As and where you have these tough points, you might want to use the forceps to just drag it slightly off that area of traction, and just keep going that way. You have to keep modifying your plan as you keep going, but you have to have a set plan earlier. And the first plan is to remove that thing off the gliotic folds and the tractional folds, the tough vitreous off the posterior pole, and you can see it's just coming off. So you have to keep identifying those areas of attachment. That's important, and that's where the great visualization system helps. So you're just removing that off the macular area, and in a minute you'll see the dragged macula just below. You can see that xanthophyll pigment just showing up now. And again, in this area, once you have to keep looking at, the whole thing will be a little dynamic. The dynamics will keep changing. You see now, you see that fold coming up, and I've pushed that tractional fibrotic vitreous away and identify a plane, and then you just go slowly through that. You don't have to go gung-ho right through, and then isolate it in a very gradual and deliberate manner. And once you get that, again, you might want to go back to forceps, or here, as you can see, a scissors here. So when you close the scissor, you can use it as a pick. I actually don't like using the pick a lot. I like closing the scissors, again, something Dr. Kamal also alluded to, and then use that bluntly to tease it off the retina, and at places make very judicious snips as and where you see these point attachments. And need to do that, and you see that isolating that area of the fibrotic tuft. What was a large sheet has now become a small tuft. Keep going ahead, and I'll just move ahead in the interest of time so that I can show you some more videos. And then again, you see, using that thing, that big fold there is the critical one, and that is where if you make very rapid movements, again, like what reinforcing what Dr. Kamal said, very fast movements, rapid movements, pulling, holding, and yanking it off will just create a massive tear. This is a retina which is not your regular chronic RD. This is a pathological retina. This is FEVR. So the retina itself, you can see the exudation temporally just right there. So you can see that this is a retina which is pathologic from the start, and then you just ease it off, take the folds off. Now we back to forceps, certain areas. So you'll have to keep adjusting your technique. Just isolate that, and then just trim that thing. And then once you're done with the posterior pole, you see there's not too much of collateral damage. You tackle the periphery and apply the same kind of principles that I mentioned. You can see that exudation here temporally. Okay, so I'll go ahead quickly to the next video, which is ROP RD surgery, which is again a pretty challenging and complex case. Not that we've done too many of them, but here this is completely a closed funnel ROP RD, which is the access through the regular port sites would take the cannula and your instrument subretinally, and the moment you have a cut or a tear in the retina, it's almost the end of the surgery. So going in through the anterior, putting the 25 gauge cannulas in through the anterior port, you see there's the fibrotic gliotic tissue right there. I'll just move the advance the video past the thing, and then you see using the forceps and the light pipe, just taking the synecdoche off the gliotic capsule. Just move further, again in the interest of time. So using the pick to open that little gliotic element before, and you can see sometimes once you remove it, sometimes it's so tenacious, the vitreous, as I mentioned in kids, especially the premature kids, that you need to actually do it more often than once. So again, this is the next skytic gliotic component. So this is the skytic layer. As you see, you can see above that there is one gliotic component, and then below that there's again another. And then we're using the scissors through that to identify the central gliotic tuft, which is yanking and tethering the retina together. And then now we're inside. And then again, you just isolate that. The important thing is not to create breaks. That's the most important thing. Once you create a break, you might as well close and exit. So you just remove those traction points very slowly and very gently. And if you've done that, then you can come off, and you can, if it's larger, suture the thing. So I'll just wind up with a quick GRT surgery. This is again using, because this was a 360-degree, this is a traumatic case, closed funnel. Again, not closed funnel, it's just, almost closed funnel. So again, used by manual, because there's a lot of gliosis, just go inside. First remove that, put in the PFCL to open that, that crumpled cauliflower. Again, used by manual to remove the edges. The edges have to be free of itches. This is very important. Otherwise, what happens is very often you'll have the entire, after surgery, you'll have the next day when you see the whole thing would have slid and come centripetally. So you slowly put in the PFCL and let it move in, put in the laser, affix it. What's very important after this is this particular step. This is, doing the fluid air exchange. As you should walk, I always tell my fellows, walk along the edge of the GRT. Make a clean edge, walk along the edge so that has to be dry. Take your time, do it repeatedly. Then finally, we are doing a fluid air exchange, and you can see that meniscus coming in and then finally putting in the oil. I think I'll stop here. What is more important, I'd like to actually show you something which is not done very regularly. I'll change track from these complex, these tractional complex RDs to what is not done very commonly, subscleral sclerectomy for a uveal effusion RD. This is something which is not diagnosed very commonly, but just a minute. So this is just at the area of the equator. We're making a trapdoor, which is the way to do for uveal effusion RDs, the anophthalmos RDs. Oh, it's done. Oh, what happened? Wire hill gaya. Sorry, there's some issue with it. So, just 1 second. can I just show this video just for 1 minute? Would you like to see that? Yeah. That I have done. Yeah. Nine. No problem. Yeah. Mike.
I request the next speaker, Dr. Vishal, to come up to the podium. I just have one question. In case of PVR, recurrent RDs, do you use any special techniques like either high density silicone oil or PFCL silicone oil sandwich, or you leave PFCL in situ at any point of time? What are the different ways you handle them?
Yeah, I like to keep it simple. I just like to follow the same sequence that we would do normally. First remove all the vitreous traction. I don't do too much of this. I know some people, there's been talk about using PFCL for short-term tamponade and stuff like that, but I personally don't like to go in for that. I like to take care. Once you, keep the concept simple. You just remove the vitreous cleanly as much as you can to the best possible extent, and then go in doing a regular fluid exchange and put in oil. I keep my approach fairly simple that way.
Thank you very much.
Thank you very much. Thank you.
So now I invite Dr. Vishal Agarwal to talk on simplifying the art of ILM peeling for the beginners.
Thank you, Dr. Raja. Thank you, VRSI. Good morning. I'll be speaking very basic things about ILM peeling specifically for the beginners. So starting from tip 1, you don't reach the ILM without removing all the patient. First, remove the posterior hyaloid. I know this is not the part of the ILM peeling, but you will not be able to stain the ILM without removing the hyaloid. So you can do that in 2 ways. You can stain it with the tricot, or you can do it unstained also. So for the beginners, it's always good to stain the hyaloid with the tricot, apply a suction, and you don't have to pull very aggressively. It lifts up on its own, and you can do the complete vitrectomy. This is a video of another form, unstained PVD induction. As the media is clear, you can see the ERM hyaloid complex lifting up and the fluid wave going to the periphery. So that's one way of doing it. If you're confident of PVD inductions, you can do it the unstained way also. The second barrier, of course, is in many cases we find a ERM. So there'll be a patchy or poor staining if the ERM is present. So ensure on a preoperative, especially in the macular hole, there is a ERM. So you can stain with the trypan blue, or you can peel it with a negative stain also. So this video is of a staged peel. So we found that there was no staining with the brilliant blue. So we stained it with the trypan blue, and as you can see, the ERM is getting lifted up in one piece. It's a thick gliotic one-sheet membrane. Then we again went to brilliant blue, and as you can see now, there's a diffuse homogeneous blue staining, and then you can proceed with your ILM peeling. So there's no point in restaining with BBG unless the hyaloid or the ERM is removed. The third tip, you have to have patience. You turn the infusion off. You inject BBG, you have to wait for 30-40 seconds. You just cannot flush it immediately. Otherwise, initially, of course, you need to have a good contrast to peel. And the best way is, of course, the pinch and peel. Of course, you can use the DDMS, or you can use the finesse loop. And any gauge, 23, 25, 20 gauge initially. It's a matter of your subjective preference. A slide about the basic financial interest here. There are 2 forceps mainly used, the DOC and the Alcon. So for the beginners, I would suggest you use the DOC one, because the curve at the end is a little less acute than the Alcon one. Of course, Alcon gives you a better view of the tip, but then again, it's personal preference. So this is the standard technique. You instill BBG after turning the infusion off, wait for 30-40 seconds, and start around the inferior temporal part, because if you create a break initially, so the scotoma resulting from that break is less. And then you go in an onion peel fashion. A good idea is to get a flap over the hole, and re-grasp at the broader range, and do not do a 360-degree peel with one direction of the peel. You can go and change the direction, and then finally go into the air. Viewing systems. Of course, these all videos I showed were in the wide-angle view, but initially always use a macular lens in high magnification to better visualize the hyaloid, better visualize the ILM. Of course, after you gain experience of, you feel comfortable for ILM peeling, you can go under the wide angle. But initially, high magnification with a macular lens is preferable. So this, again, as I told you, is the negative staining of the ERM. As you can see, the unstained part in the center, and there is a ERM and a ILM. So this is the irrigating macular lens. So you peel it with high magnification and you can see the ILM very clearly, and the ARM comes off with the ILM because of the negative staining. Second technique of ILM peeling in macular holes is inverted ILM. So the standard technique is that again you stain the posterior pole with BBG, and then you repeatedly remove all the flaps towards the edge of the hole. Don't avulse the ILM flap over the edge of the hole. And once you get a stem, you just trim it very carefully with very low suction and low cut rate, and that is inverted ILM flap for large holes. I'm very fond of PFCL, so I'll just show you a few videos of sub-PFCL peeling. So you can use the same maneuver, the inverted peel under PFCL. The advantages are there is excellent flap reposition, it's very safe, it's very less traumatic to the macula, and of course it has a very low learning curve and it's reproducible. So this is a traumatic FT image, and you can see the choroidal rupture temporally. And the PFCL bubble, a small bubble is instilled till the posterior, till the arcade, and the same maneuver, the ILM peeling is done, and the ILM, appears a thread-like structure under the PFCL, and you can easily deposit it in the hole. So it has got very good flap stability, and even if it is displaced after indentation, other maneuvers, you can very easily reposition it. Difficult cases. RD cases, you have to stabilize the posterior pole. RD cases with macular holes, you stabilize the posterior pole with PFCL, and rest of the maneuvers are the same. So do a complete vitrectomy, stabilize the posterior pole with PFCL, do ILM peeling, whether inverted or whether the routine ILM peeling, that is your preference, but it becomes much easier than a mobile retina. Again, it's a personal preference, but initially you can do under PFCL. Just take care not to instill it with a force, otherwise the PFCL can go subretinally. Diabetic vitrectomies are a challenge because there are again multiple layers. So this is the second membrane. So you have to remove after under tricot staining this thick hyaloid layer, which is persistent even after apparent hyaloid removal. Then you stain the ARM, and finally you come to the ILM. So you have to use multiple colors: the white for the tricot, the dark blue for the trypan blue, and the light blue for the BBG. Myopic traction maculopathies are again, there's a talk on myopic traction maculopathy, so I'll just show you one video because you need larger forceps. And again, there is a vitreoretinal, so the hyaloid is densely adherent to the retina. You have to stabilize the posterior pole if there is a lot of fluid, and just make sure that you do not lose the grip on the ILM, because it is again very difficult to refine that ILM because of the low contrast. Avoid complications. You cannot do much if you create a break at the posterior pole. So the only tip for this is to avoid complications. If there is a large bleed, start peeling from the other side. If there is a tear, try to keep it away from the fovea. Small breaks need no laser at the posterior pole, and make sure that you flush the cannula before injecting anything inside the vitrectomy, inside the vitreous cavity. So this is one complication which I had initially, and it was, I forcibly injected the dye, and you can see a double macular hole there. So that's the iatrogenic macular hole next to the senile macular hole, and that was a complication because of the blocked cannula. And after the ILM peeling, actually what happens is the edges of the macular hole get relaxed and they get a little mobile. So make sure that the pressure is low and the jet of the fluid is away from the hole. As you can see in this video, after the ILM peeling, the jet of the fluid is directed to the posterior pole, and you can see what is happening. The fluid is getting under the hole, and we increase the hole size by almost 3 times, again by our mistake. So that is one complication. Some miscellaneous cases, the pit. So any case in which there is some deposits of fluid under the ILM peeling is very simple. So there are various techniques of doing a ONH pit. The preferred technique of which works best for me is just peeling the ILM and stuffing into the hole. So the BBG or the trypan blue, they give you an idea where the pit is. As you can see, the pit is easily visible on the disc. And the peeling part is very simple in that because it comes off easily. The ILM comes off easily because there's a lot of subretinal fluid there. And the point is that there's no, it does not help if you just invert the ILM over the disc. You have to stuff it gently into that small pit inside the ONH. And that closes. You even don't need to laser the temporal edge of the disc. The fluid goes off in a few months' time. So that works well with the ONH pit surgery. Sub-ILM hemorrhage, again, there's a bleed in sub-ILM, so it is very easy to remove the ILM. So as you can see, there's a large clot sub-ILM. So it's not a problem removing that. And once you remove the ILM, the blood or the fibrin, easily comes out. Thank you.
Dr. Vishal, for the excellent presentation. I think the important points is very well covered. You need to have a very good view, especially if you are a beginner. There can be no compromise on the view, high magnification, very good focus and resolution. Then the videos which we typically see experienced surgeons like Dr. Vishal, they showed very rapid peeling oil, and it looks so easy, just in 5 seconds it's all out. So beginners also tend to think the same way, but it's a slow process. You have to see the layers, so making sure that the forceps is holding the ILM and not more than that. And that's why you have the gap between the two ends of the forceps. You can see through it and see what you are holding, and it has to be a slow process. And in Ingenuity, if some people are using it now, I usually do use the the yellow filter. I get a much better contrast with BBG staining. Thank you very much, Vishal.
Thank you, sir.
I now invite Virat Kohli of VR Surgery, Dr. S.Boral, and he will talk on tips and tricks of intraocular foreign body removal. Over to you. Okay. Yeah. So you can. No, can we have Dr. Kenneth Fong go ahead with his talk, and then we'll have your talk. Yeah. Can we have this podium slides, please? Then we'll switch back.
Okay, good morning, ladies and gentlemen. Thank you very much, Raja and the VRSI committee, for the kind invitation to Jaipur. I come to India every year, but this is the first time in Jaipur, and I've really enjoyed myself so far. I think it's a great idea to continue from the last talk, because Dr. Agarwal gave a fantastic video presentation on peeling the ILM, and I think it's something all of us as VR surgeons love to do. It's one of the most satisfying procedures in intraocular surgery. So, but going one step backwards, where I work in Malaysia, we are at the epicenter of two epidemics. One is the diabetic epidemic, and the second is the myopic epidemic. So this myopic traction maculopathy is something we face on a daily basis in our practice in Southeast Asia. Almost 70 to 80% of our children are now myopic, and it's a huge problem for us. These are my financial disclosures, none of which are relevant to the talk I'm going to give today. Really, as you know, pathological myopia refers to patients with a refractive error of more than 6 diopters and also axial length of more than 26.5 millimeters. And in East Asia and Southeast Asia, it's a huge, huge problem. Our patients go blind from myopic macular retinoschisis, or now we have rechanged the terminology to myopic traction maculopathy, which can often develop into myopic macular hole. Myopic CNV is a separate issue which is well managed with anti-VEGF treatment, and there's very good evidence for that as well. Now, the term myopic traction maculopathy was really coined by one of the key opinion leaders in myopic pathological myopia, Kyoko Ono Matsui in Tokyo. And really, the reason really is this condition is not really a true schisis. It occurs in the outer plexiform layer in eyes with a staphyloma present. You often see a ILM detachment, and so the pathogenesis of myopic traction maculopathy is really vitreomacular traction rather than true splitting of the inner retinal and outer retinal layers. And we know that over natural history studies, more than 30% will develop a macular hole with or without a retinal detachment over 3 years. And the loss of vision is really, in our patients, related to the macular hole development. So before I carry on, I just want to share one of my cases that I did a few years ago. This was a young, fairly young 52-year-old male, minus 16 diopters myopia, axial length of 30.2 millimeters, quite standard for your pathological myopia patient. This was his left eye with a vision of 20/40. Because he had fairly good vision, we had a discussion about the pros and cons of surgery, and he elected to leave it alone. I observed him every few months. In November 2014, the OCT findings were pretty much unchanged. There was still some element of traction and swelling in the inner retinal layers. He then continued to follow up every few months. His vision was stable for the next 2 years. Only in June 2016, his vision began to drop a little bit, and you can see an early detachment occurring underneath the area of the myopic traction maculopathy. Again, he decided to not to do anything about it because of the fears of developing macular hole. His vision continued to drop, and in February 2017, I persuaded him to undergo vitrectomy ILM peel, sparing the fovea and with a short-acting gas bubble. The macular traction and detachment resolved, but the poor thing was that his vision dropped to 20/200. And as you can see here, this patient did not improve much over the next year or so. And the discussion points really were that he had this worsening of vision after his vitrectomy surgery. If you look carefully at the ellipsoid zone, there is disruption there seen. So looking back, what could I have learned from this straight case that I managed over 3 years? And really, just going one step back, you know that we have to treat these cases early to prevent development of full thickness macular hole, but the timing of when you should treat remains controversial. A lot of doctors would say because of the high risk of this sort of operations, surgical difficulties, we should wait until they develop drop in vision before we operate on them. In terms of surgical methods, I don't think there's really much argument that you need to peel the ILM, but we know that from studies from Taiwan, from China, from Japan, that we should avoid peeling over the fovea to avoid inducing a macular hole. So a foveal sparing ILM peel is the preferred method for managing these sort of cases. Now, this important paper that came out earlier this year from Professor Terasaki's group in Nagoya, where they looked at a cohort of about 80 myopic traction maculopathy patients, and they then stratified them into 4 types of OCT findings. And this is quite a good paper to use when you're looking at how to manage your patients. So they had 4 groups, and one group we had foveal retinal detachment, and one group without foveal retinal detachment. And in the group without the foveal retinal detachment, they divided into retinoschisis group and those with lamellar macular holes. And the group with foveal retinal detachments, they had those with a lamellar macular hole and those without. And essentially, in terms of the spread of the patients, about 50% of patients in their group had a foveal retinal detachment present. The other 50% did not, and 25% of those without had retinoschisis, and 25% of those with lamellar macular hole. And why is this important? You need to be able to educate your patients preoperatively, and you as a surgeon need to have some understanding of when you need to intervene in these patients. And just to cut a long story short, they found that eyes with preoperative foveal retinal detachment were more likely to get significantly worse vision after surgery than eyes without preoperative retinal detachments. And also, additionally, patients with poor vision initially were more likely to have poor vision postoperatively. So the points really is you need to do surgery early in patients with good vision and preoperative foveal retinal detachment. So this was the OCT of my patient in 2014, when he presented with a vision of 20/40 and already foveal retinal detachment present. And so I think that patient would have benefited from an early operation rather than watching and waiting while the condition continued to progress. So in summary, all 4 types of OCT patterns showed strong positive correlations between pre- and post-operative corrected visual acuity. Patients with good preoperative visual acuity often had good post-operative visual acuity and vice versa. Patients with eyes with foveal retinal detachment had significantly worse pre- and post-operative visual acuity than eyes without foveal retinal detachment. And interestingly, only 5% of cases that had this operation, and the technique they did was really a foveal sparing ILM peel with a variety of tamponade agents ranging from short-acting gas to silicone oil. Only about 5% developed a full-thickness macular hole. And so I think the take-home message for all of you in the audience who are going to manage your patients next week after this conference is you should look at their preoperative visual acuity and look hard for presence of foveal retinal detachments in such patients, and these patients should be considered for early surgery. So in my patient, I think if I were to go back in time, I would have offered him surgery earlier and reassured him that that would able to preserve his vision and stop further drop in vision. And I'd like to invite you to Malaysia in about 2.5 years' time, where we're going to be hosting the APO meeting. Thank you very much.
Thank you, Ken. Do you do macular buckles in any specific indications?
No, I've not done macular buckles, and I think I've been to many myopic conferences around the world, and I've not come across many surgeons who do macular buckles. Those that I've spoken to have done it. They've done it once or twice, and then they've not done it.
Yeah, I agree. And in fact, a lot of these cases are handled primarily by vitrectomy, and in recurrence cases, then you probably go in for a macular buckle. But Prithvi, you have any?
Yeah. When do you decide to put gas or oil in these eyes in the setting of a macular retinoschisis repair? Yeah.
So that's a great question. Almost all my patients are treated with gas tamponade unless they have a iatrogenic break elsewhere. I hardly ever use silicone oil for these sort of cases. Yeah, because once you've addressed the tangential traction, a lot of the problem resolves. Yeah.
Thank you so much, Ken. Yeah.
Yeah, so great presentation. You mentioned, I'm only referring to the case with foveal retinal detachment, schisis cases with FRD alone. In those cases, have you tried using no gas?
Yeah, I think I have put just air. I mean, all my vitrectomy cases have a partial field of air at the end. So yeah, I think if it's a very straightforward case and I'm confident there's no macular hole caused by my peeling, yeah, you can just leave an air tamponade for 2 or 3 days with no posturing.
I think there are studies which have proved that the results are the same.
Yeah, I agree. Yeah, you don't have to put C3F8. Oh.
Yeah, the other leading secondary question from Dr. Gua's question is that these cases can have a very long recovery time for the fluid to go away, for the retinal edema to settle down. I think in your case, just in about 2 months, it settled down completely flat. I think that was a good result. That was with air, the one which you showed with, yeah. Okay, good.
Okay.
Thank you very much. I think we'll call Dr. S.Boral for his talk on tips and tricks of intraocular foreign body removal.
So, good morning everybody. My topic is tips and tricks of intraocular foreign body removal. Troubles in managing the cases of with retained intraocular foreign bodies are diagnostic dilemma, problems in localization, associated intraocular damage, explaining the prognosis and difficulty in management. So during examination, you always look for the foreign body, like you have to search for the, like whether there is iris hole is present or not. You have to always rule out intralenticular foreign body. And whenever it is possible to do ultrasonography, search for foreign body as a irregular shape, high reflective spikes, and on B scan, you can get very high signals that can persist at the low end. And always rule out presence of retinal detachment, choroidal detachment, and evidence of infection. And ROB, if it is very small, less than 0.5 millimeter in diameter, it does not produce any kind of shadowing. So other ROBs which are difficult to detect on ultrasonography is very small foreign body. Apart from that, it is located in the anterior segment, embedded in at the plane of iris, or embedded in the pars plicata. In anterior segment, OCT is required to detect the angle foreign body. X-ray is mandatory in all cases of penetrating injury to detect the radiopaque, rule out radiopaque foreign body, both AP and dead lateral view. Sometimes some metallic foreign bodies like aluminium, where the bone density index is very less, you cannot detect the cannot be separated from the bone shadow. CT orbit is necessary to detect the foreign body, as well as for the more accurate localization of the foreign body, whether it is intraorbital or intraocular or extraocular. Other localization methods are sweet localization method. It's a old technique, and another thing, the localizing using the metal locator like Rupert Hall, Berman, or Bronson Turner localizer. MRI is particularly helpful to detect the wood foreign body, but better to avoid it in cases of metallic foreign body. ERG changes, it is for the preoperative prognostication in cases of siderosis. So regarding the timing of intervention, some studies you should intervene early within 72 hours. Some says you can delay it, but it may reduce the intraocular bleeding and decrease the inflammation, and it helps in spontaneous separation of the posterior highlight phase. So other prognostic factors are involvement in the visual axis, relative velocity of the foreign body, size, number of the foreign body, chemical nature, associated detachment, and endophthalmitis. So some foreign bodies are very toxic, like iron foreign body, copper foreign body, and the other metals like aluminium, mercury, nickel, lead. But some foreign bodies like metals like zinc cause little reaction. Chemically, other inert foreign bodies are precious metal foreign bodies like gold, silver, platinum, rock, stone, glass foreign body, plastic, and so these cases can be followed up. So strategies basically depends on the magnetic property of the foreign body, location of the foreign body, lens status, infection present or not, retina is on or off. So in case of like phakic foreign body, the management strategies depends on we have to use the you have to convert 1 port to 20 gauge, and depending on the size of the foreign body, protect the macula, because in this case the vision was quite good. So protect the macula with the PFCL. Nowadays people are using viscoelastics material, especially viscoat, rather using the PFCL. Now use magnet, then using Sandler slide, you can just do the handshake technique. You just remove the foreign body, and fortunately it's small, sometimes it's stuck to the scleral port, and then you can put one suture, complete your surgery, do some kind of laser, and remove the PFCL, and in the case with simple air. And in case of RIB with cataract, prefer to remove, I prefer to always remove by the limbal root, because basically it is a classical case, early case of siderosis. You can see the ULIS changes in the capsule. While I removed and aspirate the lens material, I have seen that one small rent is there. So I have not put the IOL. Basically, if you are planning to remove the foreign body in case of cataract with foreign body, basically in these cases I am not putting the IOL. I am using the posterior capsule rent area to remove the foreign body. And I used a bent 24 gauge needle to dislodge the foreign body from the impacted air site, and then with the help of suction of the cutter, I am just lift up to the behind the posterior capsule and use the magnet to just introduce the foreign body inside the anterior chamber, and deepen the anterior chamber with the viscoelastics material and remove the foreign body, the limbal root, and then you can inject the IOL in the bag, and in the end of the case after doing laser and some kind of gas. So in case of aphakia, it is difficult. It is preferable to remove the foreign body through the limbal route. Like in this a very challenging case where I can, after clearing the vitreous hemorrhage, I've seen that foreign body might be there in the stuck to the scleral coat. So I used main 24 gauge needle, and what happened, the foreign body went vertically and then become horizontal and become trapped to the scleral coat. Whether to remove or not, in which approach is preferable. So I was in a very confused state, like it is a very tough situation, but the fovea macula is quite healthy. So I'm trying to use the foreign body forceps as well as the magnet also bimanually. So this idea came to my mind by giving releasing incision around the site of foreign body. So I used 23 gauge forceps, giving the scleral nicks around just to release the trapped situation from the foreign body and make the foreign body intravitreal, so that now just use the 24 gauge needle, bent 24 gauge needle and magnet. Now you can see the foreign body is absolutely it is traction. It is release of trap situation. Like you can remove the foreign body from the limbal root. Basically, I've done the lancectomy beforehand. It's quite large and thick foreign body. After doing fluid exchange, you do laser, and at the end of 4 months after removing the silicone oil and glutathione implantation, patient gains 6/9 vision. This is another very challenging situation, and always the RIB cases take it as a challenge. Like it is a phakic case, clear lens, and the bulbous end of the long foreign body is just behind the lens. It is a clear lens. So I started doing vitrectomy, remove all kind of adhesions surrounding foreign body. And what happened, the foreign body is very much stuck to the scleral coat. So it is very difficult to remove the foreign body, to release it from the sclera. So now I was using bimanually, using magnet in one hand, using intravitreal forceps. It was not coming out, even after really, extending the 20 gauge incision. So what next? Then I remembered the John Wayne and his famous film Kothari, and used the lasso technique here. So this is the thing. It came to my mind at the time. At any kind of any kind of technique, it is always welcome in your situation, because you are the best person to manage that case at that time. So pass the knot through the bulbous end of the foreign body, tighten it, and just giving a strong but smart traction, and just you could see how big it is, more than 20 millimeter, almost the size of a foreign eyeball, just like that. Release the traction, remove all kind of adhesion, release the retina from the underlying, there was retina incrustation was there, and injected oil. After 4 months of surgery, after silicone removal and phacoemulsification, patient again gain 6/12 vision. This is non-metallic RIB. These are very simple cases. Like it can be separated like sulfur granules, clumps. You can remove it through the. So non-metallic foreign body, this kind of situation are very easy. Sometimes RIB cases are always they are very much intriguing. Like in the case of history of a car accident, vitreous hemorrhage, choroidals, and you can see weakly radiopaque foreign body here. So this is, I thought there must be foreign body, iron foreign body, but no RIB detected on ultrasonography. But when I gone inside, I have seen something different picture. It's a very large glass foreign body. I think Dr. Prashant also agreed with glass foreign body as always dangerous. They're very risky. So I took the approach from the scleral port without damaging the lens. So I made a very large scleral incision pars-plana route, but it protected the macula. Disc was looking very pale intraoperatively, but preoperatively look was not that pale. So I tried to dislocate the glass foreign body towards the scleral port, but hypotony, due to hypotony is a very large scleral incision, it was creating a lot of turbulence in the PFCL. It was a dare-to-bear-like situation. I tried to remove the foreign body with the help of many things, but it was creating a lot of large breaks and ultimately tear. So this kind of real-life situation, it may happen. So I closed the wound. Again, did lancectomy. Used the suction of the silicone tip cannula and followed by the extrusion method with the metal tip fluid needle, and now remove the foreign body It's a very, like, I thought it must be half an hour surgery, it took 1.5 hour surgery. So it is always unpredictable, always intriguing. And this see, such a very thick and large might be from the wind, like windshield, breakdown of the glasses, pieces of glass has come. After 3 months of this surgery, patient is still, I have not removed the oil, this is looking pale. Vision is very poor, but still looking okay. ROB with endophthalmitis is always challenging. You have to search for the foreign body. This is another tricky situation. Remove all kind of vitreous abscess. Here I have, okay. So I use the suction of the cutter here, and as I have done the linguectomy already, I removed the foreign body through the paralimbal route. So you have to choose the limbal route, you have to keep your minds open, you have to take all kinds of approach to remove the foreign body, but whatever approach you are doing, that should be the best approach for you at that time, at that moment. So never repent after doing the surgery. You can always criticize yourself, but don't let the others to criticize you. Thank you.
Thank you, Dr. S.Boral. You have proven why you are Virat Kohli. So can I invite Dr. Jain to come up on stage and be also part of this panel? So Manish, do you want to say anything about the foreign body forceps that you have designed? And in some of these cases, it might be very useful, like the irregular foreign bodies, which you had the glass foreign body. In fact, I had one case where I had to do an endoscopic vitrectomy. Cornea was completely lacerated, no view, and then with the endoscopy, it was a struggle to remove a large irregular glass foreign body. So I had to just leave it in there and then still waiting for the cornea to clear up sometime, and then...
with the glass foreign body, with Manish forceps, I have seen his forceps, I used 1 or 2 cases, but glass foreign body, it is very slippery. You cannot hold it. Metal foreign body is rough surface, you can hold it. Glass foreign is absolutely smooth. Antenna is a very small foreign body, you can pick it up, but large, thick, such a like three-dimensionally large.
Yes. So Manish, do you have any comments?
Yeah. So how I got the idea of developing the forceps was because of the glass foreign body that I could not remove, and eventually I think that it is published in IJO December issue, this forceps, and it has 4 claws which can pick up in anteroposterior direction. You can go in anteroposterior direction. You have to enlarge the sclerotomy, it's 19 gauge. You can go through, you can go in anteroposterior direction and pick up from the retinal surface. The idea is that you don't have to put any element under the foreign body. So for basket design, you have to go under the foreign body, use bimanual method to engage it into the basket. But here we can go in anteroposterior direction. It opens almost up to 10 millimeters. And Dr. Naresh Babu was yesterday describing that he could remove a large glass foreign body. I'm in private practice, so largest I have removed is a stone which was about 13 millimeters, but no glass foreign body that I have removed with this.
Yes, I have a small idea, like little idea regarding the glass foreign body, what you can modify. You have 4 paws, and you can put some kind of rubber-like material here so that when it grabs any object. It may be slippery, but if your tip of the paws are metal and glass is absolutely smooth, so it will create very less frictional forces to hold the foreign body. And if it is soft tip, like rubber-like material is there in your paw, and if you hold the foreign body with glass, even glass foreign body with that forceps, that will create quite a big amount of frictional forces, so that it can be.
So that's an excellent idea, but
yes.
One of the advantages of this particular forceps is that the claws can be completely retracted, so you can go through a smaller sclerotomy.
Yes.
If we use some kind of rubber tips, then probably we cannot have such a small sclerotomy. So you can, what we can do is you can on table you can probably take small pieces of the belt buckle and just engage them in the claw and try and hold it, so we can improvise on table with that.
Yeah, great points, Manish. Before I invite Vishal to make his point, I want to personally thank Manish for providing us that forceps. I find it of awesome use in my area of work in Srinagar, where regularly I have to remove pellets. Before, pellets used to be absolutely smooth, without any corrugations, absolutely dead smooth. those pellets, and now of course they have become hexagonal in shape due to whatever reasons best known to them. So I have to thank you personally.
Thank you, sir.
We shall go ahead, please.
So, as this is a basic class of vitreoretinal surgery, I'll just like to make 2 points for the starters. First is, as Dr. Boral showed in a video, you do all the maneuvers. First you loosen up the foreign body, you do the laser, you attach the retina and then enlarge the port. Do not enlarge the port in the beginning, otherwise it will create hypotony and mess, and there will be a lot of turbulence of the PFCL. So enlarge if you are removing it through the limber route. So enlarge the incision after doing all the maneuvers. The second point I want to make is if you're removing through the pars plana, even if it's a small body and you're sure that you have made the incision of the pars plana right and you're not in the retina, if you indent, most of the times you can see a small nick or a break, and that is the point where most of the re-RDs are after an uneventful IFB removal surgery. So make sure that area is cryoed or blanketed with laser, the area where you're removing from the pars plana. So that is very important. Yeah.
Now, thanks Subhendu, excellent talk. I now invite Dr. Neeraj Sanduja for his talk on I think foreign body, management of intraocular foreign body. Neeraj.
Good morning, everybody. So my presentation is going to be a little bit repetition what Dr. Boral did. So my talk is on algorithm for management of retained intraocular foreign body. The primary goal in management of intraocular foreign body is not just to remove the foreign body, but to prevent endophthalmitis, to prevent any retinal detachment, and to reduce chances of late maculosis. In evaluation, it is very important to see in any open globe injury whether there is a foreign body, whether this is intraocular or intraorbital, whether you are dealing with multiple foreign bodies, and exactly where the foreign body is located, because unless you know where the location is, you won't be able to find out in the eye. You cannot just go fishing into the eye. And you need to see whether any coexisting conditions like endophthalmitis, vitreous hemorrhage, or retinal detachment is present. It is very important to ask the patient what type of injury it was and how exactly it happened and what type of material was being used, like he was doing chiseling or what exactly was doing. Even I'll show you a video of glass foreign bodies of unique presentation. Once you have taken the history about the foreign body, you need to evaluate the patient on slit lamp to see whether any evidence of foreign body is there or not, to see whether any iris hole is there, any cataract is there, any wound of entry into the sclera, if you look here, hyphema, cataract, or any side effects of maculosis are there. In direct ophthalmoscopy, if view is clear, you can encounter, see any retinal phlebitis, vitreous exudation, hemorrhage, and the impacted foreign body itself with a retinal break. If you look here, in direct ophthalmoscopy, if visualization is good, it gives you the direct visualization of the foreign body. If in case you are not able to see the foreign body, then X-rays we don't do as a rule in our cases, but sometimes patient is not able to afford the CT scan, then maybe you can order X-ray just to detect any metallic foreign bodies, because you are likely to miss wooden and glass foreign bodies. Ultrasound should be done in a very gentle manner because the globe is mostly open in such cases. It tells you about the metallic and non-metallic foreign bodies, and also whether you are dealing with any retinal detachment, suprachoroidal hemorrhage. But if the foreign body is too anterior within 1 millimeter of sclera, or if you are dealing with glass foreign bodies, you are likely to miss such foreign bodies on ultrasound. CT scan is a gold standard to detect exactly where the foreign body is there. And in my routine cases, like I always order CT scan in all patients of retained intraocular foreign body, because you are likely to miss the number of foreign bodies, the location of foreign bodies on ultrasound. And sometimes you are not able to do the ultrasound because of the open globe also. So CT scan should be done also from the medical legal point of view to see where for the documentation and for exact visualization. MRI is rarely indicated, because if you're suspecting foreign body but you are not able to detect on CT scan, especially if it is a wood foreign body or plastic foreign body, then you can order for MRI also. And especially if the foreign body is close to the orbital apex, sometimes you are not able to see on the CT scan, so these things are picked. UBM, rarely we do if you have that facility, you can do it for those foreign bodies which are into the anterior segment of the eye or in the angle. The general principles in management is you have to do a careful examination to avoid the further damage. You have to give prophylaxis against infection by giving IV antibiotics or antibiotics and tetanus prophylaxis. And primary repair of the wound should be done whether you are able to take out the foreign body in the first instance or not, and you need to treat the concurrent pathology. As far as the early or delayed removal is concerned, we always remove the foreign body as soon as the corneal clarity permits you to remove the foreign body. Otherwise, you are likely to end up with more vitreous exudation, more metallosis, and grave visual prognosis. Endophthalmitis, you should always suspect with any retained foreign body when you see any exudation, because it is seen in 11 to 26% of cases with foreign body. As far as instrumentation is concerned, you need to have a rare earth magnet, which is available in maybe 20 gauge size or 23 gauge size, and different types of intraocular forceps have been designed. Even ManeeshBapaye has designed a wonderful foreign body forceps, which are used to take out the pellets from Kashmir. Terrorists had some pellets having, and these were quite big, so we had to use those foreign body forceps. If the foreign body is in anterior segment, it is much easier to remove, and you just have to make a side port and take it out. External approach for the foreign body is done when you are suspecting the foreign body in the ocular coats itself, not into the vitreous cavity. This is how you can see this foreign body has been taken out from the external approach. But yes, you have to go behind, do vitrectomy, and manage retinal detachment or vitreous hemorrhage, whichever is inside. As far as magnetism is concerned, non-magnetic foreign bodies are more difficult to remove. Magnetic foreign bodies, because you are able to hold the foreign body with the magnet and take it out comfortably. And the steps of surgery, you need to close all the wounds, do a vitrectomy, and clear all vitreous strands from the foreign body, and protect the macula by putting PFCL once you intend to take out the foreign body, and you need to do a complete vitrectomy and treat all retinal breaks. And scleral buckling we do in cases where there is associated retinal detachment, or if there is a break peripheral which requires external support and you are not going to do lensectomy in such cases. This is a video of patient. We are putting a buckle here because there was a break anteriorly and the foreign body was impacted over the posterior pole. We are going ahead with the vitrectomy. And once the foreign body was, all the vitreous was removed on the foreign body, then we did laser around the site of foreign body infection. Now we are going with the MVR blade and cutting the capsule around the encapsulated foreign body. And it is very important to remove this capsule, otherwise you are likely to tear off the choroid also. And once this foreign body is removed from the capsule, you can take it out with the help of magnet or even directly with the end gripping force. So you can see such a large foreign body, and as rightly pointed out, like you need to enlarge the wound just before you intend to remove this case. And this is another video where you can see a multiple foreign bodies. These are glass foreign bodies. Oh, this is not playing. Okay. So these were multiple glass foreign bodies. These were bangle pieces within the eye, 11 pieces which were there in the eye, and before pre-operative picture and the post-operative picture, you can see the retina is well attached. And another case of endophthalmitis with corneal tear intraocular foreign body. Timely management can save such eyes. And also very important, sometimes you see the suprachoroidal migration of the foreign bodies also during surgery. You are looking at one side, but the foreign body is not there, then you need to see where exactly the foreign body is. This is one of our cases. So to conclude, all patients with intraocular foreign body should receive broad spectrum antibiotics to decrease the chances of infection. And the treatment of foreign body should begin with the treatment of globe repair. Thank you very much.
Thank you, Dr. Neeraj, for a wonderful presentation. You had a lot of complex cases of foreign bodies. So in the interest of time, we will move on to the next presentation. I now invite Dr. Prashant Bhavanpally to talk on tackling complex PVR for the beginners.
Good morning. At the outset, I thank the VRSI for this wonderful opportunity, and I'm going to speak on management of complex PVR steps for the beginners. Dr. Rajendran has made my life quite easy. Initially, has covered up a lot of it. As we are all aware, retinal detachment is associated with almost 5 to 10% cases with PVR, and PVR is the single most commonest reason for failure of primary retinal detachment surgeries. Complex PVRs, anything more than PVR C grade is called complex PVR. Once we have a PVR, does it mean scleral buckle has no role? This is a classic case where we have a total partial retinal detachment, old partial retinal detachment with a subretinal gliotic bands and a star pupils in 2-3 quadrants. This was a young patient. We did a scleral buckling, and in the last 10 years, this patient is doing well. So even if it means a star fold, even if it means a subretinal gliotic bands, you can get away by doing a scleral buckle, especially so in a young patient. Encircling band, is there any role? Yes. In a young patient, when you are doing a vitrectomy, when you have inferior breaks, or a patient where you are seeing a very foreshortened retina, in that cases, you are supposed to put an encircling band. All the classic steps of vitrectomy, right from placement of infusion cannula to PVD induction base excision, has to be religiously. You have to go through each of the steps while tackling a complex PVR, because each small step contributes to at the end of the day for the success of the surgeries. The challenge begins right from the placement of infusion cannula, because many a times these are old detachment with soft ties. They have a choroidals, or they have an anterior PVR where the retina is pulled into the periphery. And the strategy here is to use various types of, and this is a small video which we will see how we manage this case. This is a subretinal infusion cannula, so the only thing is change the port position of the port. We did place, and after a certain time, again it got incarcerated, and the only option was to do a relaxing retinotomy at the site of infusion cannula. Then the second important step is induction of PVD. Many of these patients are young, they have vitreoschizis, and the basic challenge is mobile retina and a very limited space which you have to play with and induce a PVD. And here you have to be really very patient. You have to move from this quadrant, from next quadrant, and you have to be very patient. Otherwise, you will end up creating a retinal breaks even in the posterior pole, and your PVR will be left aside, and you will have a posterior breaks. So the challenge is you have to be very patient. Sometimes you might take minutes in inducing PVD, but this is a very important step in management of PVR. Sometimes the funnel is too closed, and you will see that there is hardly any space for you to create. I'm trying to induce a PVD with the help of a forceps, but I couldn't find a space. So what we did was we created a peripheral retinotomy over here, and then I'm draining through the break retinotomy over there, and you see a flattened retina which now permits me further steps in the surgery. So this is how you create a space when you have such a limited space. Or sometimes you feel that you have completed a PVD, and then you see there is a membrane, and this is an incomplete PVD in a very high myopic, and you use a forceps to peel off. So even a basic step like this in a case of a PVR or in a retinal detachment can be a challenge, and you have to ensure the completion of PVD in all these cases. Just inducing a PVD in the posterior pole is not enough. The peripheral PVD is also equally challenging. As you see thin atrophic retina, here you're trying to induce PVD with the help of a vitreous cutter itself, and it takes a lot of time and a lot of patience. Otherwise, you end up creating many more breaks and then have more of a problem. Sometimes the retina, when you're trying to peel off the peripheral things, retina is very mobile, and then you stabilize the posterior pole with the help of a PFCL, and then you peel off the membrane by simple with the help of a cutter, or as in this particular case, you can use, here the vitreous is very densely adherent over the thin atrophic retina, and here we are trying to use a forceps to peel off the circumferential type of attachment of the vitreous under the support of a PFCL. So these are the various strategies how you tackle removal of posterior peripheral vitreous. Most importantly, we know that we need to remove the vitreous attachment to the lattice. But remember, lattice, when you're trying to peel off the PVD, you can create large breaks. And sometimes you have to be just satisfied by shaving the vitreous to the best extent possible. Most important edge is the anterior edge as well as the posterior edge. You have to be very carefully trimming of the best possible vitreous And that is how you have to induce a vitreous detachment, complete vitreous detachment. We prefer to do peeling of ILM in all cases of detachment with PVR, and the challenge over here again is a mobile retina. The trick over here is to start the peeling from the disc where the retina is attached, and there it is possible. Many of the surgeons do peel it under PFCL. That is another option. As we see this particular, the PVD is sometimes very densely adherent to this atrophic retina. As you see, I'm trying to peel off the vitreous from the posterior, and I end up creating a break. And once you have a break at the posterior pole while you are doing, you have to change the force of traction, removal of your posterior vitreous detachment, which you are trying to do. And most important, even if you create a break, you have to treat it like a macular hole. You have to peel off the membrane ILM all around it, and then you can get away without doing even an endolaser at the posterior pole by tackling it under the oil. A macular drag like this in a case associated with angiomas, here the vitreous is very densely adherent to the retina, and you have to use the cutter. Sometimes you have to use the forceps, and you have to ensure that you have to remove the vitreous right from the disc. You have to start, and you have to really struggle a lot with all these steps during the surgery. And after stabilizing, after trying to remove it with, again, after putting a bubble of PFCL, I have created a space. I'm trying to peel off the residual membrane, which is very densely adherent. Then comes, once we have removed the peripheral vitreous, comes the base excision, and base excision is a very essential step in management of complex PVRs. And here you see the base excision you have to do even in a phakic patient. You should not compromise with this particular step, or otherwise the only option is to put an encircling band, which we do not do in our routine settings. And the trick over here is to press very hard so that you bring the pars plana into the mid-vitreous cavity and excise, and this is possible to excise base even in a phakic young patient in a hypermetropic eye as well. Then comes the interface vitrectomy. You have to make every effort to remove each part of vitreous, and you see this interface vitrectomy where we have put a PFCL bubble and we have started using air, and at the junction of it, using a highest cutting rate and minimal suction, you are removing the residual vitreous, which you can better visualize under the air at this particular point of time. It's a matter of debate whether it causes sometimes attraction, but yes, many times when you are doing this interface vitrectomy, you can pick up the vitreous, residual vitreous base, and you can definitely complete the base excision more perfectly. Here is again a case of a interface vitrectomy in another case where we are doing, and you can see the visualization of the vitreous, residual vitreous, which is more better when you are using a air media. You can see right up to the ora serrata, which was not visible in a routine cases. After you have completed the vitreous removal, then comes the membrane peeling. First, you have to remove the posterior pole membranes with the help of a forceps. Here, you have to hold the membrane at the center of it and then start peeling off. You have to be careful, remember, because the vitreous, here the retina is very atrophic in a PVR cases. And then once you remove the macular membranes, then you go to the peripheral membranes, start peeling off. The trick is just hold it at the center of it wherever you see a star fold, and then start pulling it from inside out. And one by one, you have to slowly remove all the membranes at the posterior pole. Sometimes, as you see, the peripheral membranes in this angioma case, you have to peel off sometimes with a forceps, sometimes with a cutter, and unless you relieve this fibrous tissue, which is causing the drag at the posterior pole, you cannot get away. And so you have to be very diligent and spend more time removing each part of the vitreous. Once you have removed the surface membranes and you see subretinal gliosis, then you have to tackle the subretinal gliosis. This video, yeah. This particular video, you will see, what you do is, I do a punch retinotomy first. I dithermize that retina wherever the best, most acute angle of the traction band is there, and then pull off with a forceps by just doing a punch retinotomy, and slowly you have to remove all the subretinal bands one by one, and then you can relieve the subretinal traction as well. Once you have removed the apparent posterior pole and up to the equator, then you start putting a PFCL. to see the mobility of the retina. And you start putting the retina and you will see the flow of the fluid which is coming out, which tells that you have cleared the vitreous right up to the edge of the hole. And this flow of movement, it tells you that the retina is quite mobile. Yeah, last. Then, in spite of that, if there is a retinal shortening and you are not able to get away, then you have to do a retinectomy in such cases. And retinectomy can be either radial or circumferential depending on the type of the retinectomy traction. If it is a circumferential, then you have to do a retinal. I have converted this hole into a radial retinectomy just last minute for this particular case. And
I think Prashant,
last
we have to vacate the hall by 10:30.
Yes, yes. Yeah. And 360, if you are such a closed funnel whole RD, you have to do 360 retinectomy. But remember, retinectomy should be limited. It should be adequate enough, but try to avoid that. Once you have a retinectomy, then you have to manage anterior leap. You have to excise the anterior leap of the GRT to prevent anterior segment neovascularization. And then treat any retinectomy like you treat the fluid gas exchange that we do, PFCL air exchange. We dry off every part of it, retina, and then unrolling can happen once in a while, which can be done with under the PFCL or other techniques. So at the end of the day, if you have a complex PVR, you have to be diligent right from PVD induction to the last step of subretinal gliosis to retinectomy, and then only you can achieve a good success rate. Thank you.
Thank you, Dr. Prashant. Is the last speaker Dr. Himanshu Shukla here? Okay, so in the interest of time, we will move on to the last talk. The title is VRD, the turning point in my career.
A very good morning to everyone. My topic today is Vitreoretinal Development Program, the turning point in my surgical skill development and my journey thereafter. I would like to thank the VRSI team, Dr. Vishal Gupta and Dr. Narayanan, for giving me the opportunity to present here. I have no financial disclosure. To start with, basically, I was trained in the era where the training was done in 20 gauge surgeries. So basically, we created periotomy, made infusion ports, sutured those ports into position, got scared with excessive movement of the retina during vitrectomy. We were uncomfortable in doing shave. We used scissors and bimanual technique too often. And post-operative inflammation and delayed rehabilitation was norm for us. Basically, you are going for retinal surgery. What do you want? We were not interested in going to MIVS. Basically, we were comfortable with 20 gauge surgeries. We were giving decent results. At that time, we did not understand the parameters that well. And since it was a new technology, why to change? Basically, we call it living in the comfort zone. We were introduced in the program in the year 2016. It was a 6-day program at Arvind Eye Hospital, Coimbatore, which was basically observation, explanation, and case-based discussion. And the basic aim was surgical skill enhancement. So what did the program do to us? It gave us the confidence and drive to shift to micro-incision vitrectomy surgeries. We started understanding the concept more clear with respect to flow rate, the sphere of influence, and how to use cutter as a multi-purpose instrument, and basically what advantage we will be giving to our patient by shifting to micro-incision vitrectomy surgeries. If we see our statistics, in 2013, most of our surgeries were 20 gauge surgeries, and now since last 2.5 years, we have shifted mainly to 25 and 27 gauge surgeries. If you see the stats in the diagram part, you can see that before the course, we were mostly the 20 gauge people. Now we are usually 25 and 27 gauge. The changes in the results are duration of the surgeries, which has basically come down. Post-operative day 1 picture is better. You can actually show the relatives those eyes. Patient comfort is far better. The rehabilitation is earlier. The use of topical drops has come down. And basically, we have more confidence in dealing with tough cases now. So if you see, when we started doing retinal detachment in using micro-incision, these were our initial surgeries of 25 gauge, and we were actually very scared going near the retina. A slightest movement of the retina while we are trying to do a vitrectomy would give us chills. So we tried to do some amount of vitrectomy, removed whatever we could. The amount of damage to the retina that we induced at that time was much because we didn't understand the parameters that well. The only advantage of doing these surgeries at the beginning was that we realized that with the help of cutter itself, you can go close to the retina and deal with the membranes, whatever they are, and even use some amount of vacuum to remove these membranes. The confidence within first few surgeries itself was such that we were able to drain with the help of cutter itself. And now, after 2.5 years of our experience with the micro-incision vitrectomy, we are doing these surgeries faster. We are going near to the retina at a higher vacuum. The damage that we now induce to the retina is much less. We are able to do shaving and removal of the peripheral vitreous, peeling of it far more easily. Even dealing with such membranes at the posterior pole, earlier we were scared to even go with the forceps, but now with the help of cutter, we are at least able to find out what will be the best site to peel through, what should be done. Although we have still not learned to remove these membranes with the help of cutter, but we can use forceps now to remove these membranes easily from the posterior pole. We still drain actively with the help of the cutter, and now we have started doing shaving under air so that we can shave off the entire vitreous. The advantage of it being that when we remove the silicone oil in such cases, our redetachment rates has come down and the operative results have become better. Also, we have shifted to we have started shifting to 27 gauze surgeries for doing retinal detachment cases. In our personal experience, we don't find much difference while doing 25 and 27 gauze surgeries. The time of the surgeries, the peripheral shaving, the dealing with the fluid, removing PFCL, all these steps are similar if you are doing 25 and 27 gauze surgeries. The only difference that we find in such cases is the rehabilitation. So this patient, this is the third day post-operative picture of the patient. Third day, we never got such pictures in 20 gauze surgeries. When coming to macular surgeries and our shifting to MIVS, if we see the routine macular surgeries, we don't find much difference as compared to our old surgeries. Peeling of the membrane over the maculas was done in a similar fashion in 20 gauze, and we were comfortable by restaining it, again peeling it. We didn't had any problem much. The only game-changing when we compare MIVS for macular hole surgeries were for these detached retinas along with macular holes. So in such cases, earlier when we were doing such surgeries in 20 gauze, we were trying to avoid cases like these, manage it like conservatively or do something. But now with the advancement, we are able to do such surgeries and give good results even in such cases. Such traumatic holes with detachment, earlier we were just settling the retina and bothering not about the hole, but now we even try to peel in such cases, although I am not very comfortable in peeling with PFCLN, but still we are able to give them decent results. The best thing that has happened to us after shifting to micro-incision vitrectomy has been dealing with these diabetic vitrectomy cases. Earlier in such cases, we would basically go always bimanual and try to remove the membrane as less as possible. The vertical scissors were our best friend at that time, but now the proportional reflux and using the cutter as a multi-purpose instrument has become a norm for us. We basically use the cutter, use proportional reflex, then create a plane between the membrane and the retina, then dissect it with the help of cutter. The main aim here in all the surgeries now has become to convert these membranes into small pegs or small islands and then deal with these small pegs separately. And with that, our results have definitely become better than what we had in the 20 gauze era. The second advantage that we have in diabetics is combining the surgeries using micro-incision vitrectomy. Earlier, if the patient had a cataract and had a membrane which we wanted to remove or had a complicated detachment, we would ask the patient to go for cataract surgery first. We would wait for some time and then plan for retinal surgery. But now in a single setting, we are able to do both the surgeries and the credit totally goes to the micro-incision vitrectomy systems. So that we are able to give them the same results and the comfort and the cost to the patient is also reduced. The discomfort in this is only sometimes the media might become hazy if the anterior chamber is not good. The 27 gauze hybrid port vitrectomy, we have also started doing these in diabetic cases, but we are not taking complicated cases right now. Again, we don't find much difference. The cutter does the same work what it does for the 25 gauze surgeries. we just try to loosen up such membranes, and we use the hybrid port so that we can use 25 gauge instrument to peel these membranes off, and then again the cutter used to remove such membranes. The advantage again being the post-operative rehabilitation being better. This is the first day post-op photograph. Normally we never saw such photographs earlier. And the rehabilitation, the patient was able to join in duties within 20 days. Thanks to the team, we are now taking technology at very fast level. Means the technology of 10,000 cut rate was introduced a few months back, and now we have it and we are trying to do it in our own setup. So in brief, it is a good program to upgrade from the basic skill. It also inspires from learning by self, detailed documentation of the cases and recording and reviewing, and a continuous assistance is provided for the better results using the latest technology. Thank you so much.
Thank you, Dr. Himanshu. I think there are a lot of development programs now for VR surgeons who want to improve their skills. There's a wet lab also from VRSI, which we started last year. This year there are almost 150 wet lab registrations for all the workstations, and this will be a constant feature in the upcoming VRSI conferences. So anybody who wants to brush up their skills or learn something new or hands-on from the experts like membrane peeling, ILM peeling, so this wet lab is probably the best place to go to. So now we come to the conclusion of this session. I thank all the speakers, the audience for staying back, and also Dr. Jain for being an excellent panelist. And one last announcement, housekeeping: the bags are very similar, the delegate bags, so it may get exchanged. So yesterday, Dr. Manoj Saswade has lost his bag that had some valuables. It has his name also as a tag. So if anyone has found his bag, so may please contact Dr. Manoj Saswade either in the registration desk, or he's here right now raising his hand. So if anyone has found it, you can hand it over to him. Thank you very much.